You're like,
Good evening, everyone. And this is the last module of our ophthalmology crash course program. And me, Dr. Madhumanti, and Dr. Anu Malik, we planned this program. And I hope Dr. Anu is there today. So this we they both of them had worked hard, really hard for this. Although I started thinking about this program, but they really did well, and we are extremely pleased to see the response because our average registration is 1600 to 1700 per module and average live view are 500 plus. So thank you so much to all the students across India for showing such huge response. And Madhuvanti, me, and Dr. Anu, but I feel we'll repeat this again after 6 months. We'll do this module every year, twice a year, so that this helps the people, help the students. And with this, I'll invite all the speakers here for the last day. And today's moderator is Dr. Gunjan. And Dr. Gunjan, if we have the other moderators also, or you
Yeah.
are going to run the show?
Dr. Sameer and Dr. Ankit is also there.
Okay, Ankit is there. So Ankit is another moderator. You must be knowing him from UC, the very dynamic chap. Gunjan, I think you must have seen her everywhere in cornea sessions. So welcome Gunjan and Ankit. Now please take care of this module. I'll be there, but you people has to run the show.
Yeah. Thank you so much, Prafulla sir. And this is a very esteemed honor for all of us to be here amongst the esteemed faculty and the topics that have been discovered in this talk and this webinar, which is planned very nicely and meticulously by Dr. Anu and team. And I'll not waste much time and I'll invite the first speaker, which is Dr. Poona Chandra sir. He'll be talking about genetics and he doesn't need any introduction. He has been a pioneer of any genetic disease in ophthalmology over such a long period. And sir, over to you if you want to start your presentation.
Really? Hope my slides are seen.
Yeah, yeah, yes, sir.
Thank you so much, Ulla, for the opportunity, and thank you, Dr. Gunjan, for the kind introduction. So today I'll just try and cover the topic, something which most of the students may or may not feel it's very important, but let me tell you. So this is important not only from your exam point of view and also from the practice point of view. And the future is going to be this. It's not only from the ophthalmology perspective. So, because there are a lot of advancements which are happening when it comes to the way we handle the disease, and most of the disease will have some genetic etiology. So, it's very important to understand the genetics. So basically, genetics is the study of heredity in general and of genes in particular, and it forms central pillar of biology and overlaps with many other areas like agriculture, medicine, and biotechnology. But principles remains the same. So in the genetics, the theory, understanding the concepts of genetics revolves around inherited retinal dystrophies. Okay, so that forms the bulk of the genetic eye disorders. So other than retina, there are other genetic disorders which can affect other parts of the eye, but to a lesser extent. And IRDs, we all know they are progressive, major cause of untreatable blindness characterized by degeneration of retinal pigment epithelium and also the photoreceptors eventually. And whenever we suspect any genetic disease, so it is extremely important to take a proper history. So this is one of the questionnaire designed by Iowa University, so which is quite comprehensive. So maybe you can teach one of your optometrist or assistant also to how to take. I mean, they can just go through all this question again. They can just tick it present or absent, so it becomes easy to conclude on anything. So coming to the genetic testing per se, so why do we need genetic testing? It is basically to identify the genes, inheritance pattern, and the associated mutations. Fine. So to bring back to the basics, human body is nothing but it's combination of different types of cells, and each cell has a nucleus, which in turn has something called chromosome, which is nothing but a coil structure of DNA. A segment of DNA is called a gene, and it will have multiple nucleotides, which will just the double-stranded helix. So this is the same in every part of the body. Okay. So how do these genes makes proteins? So because the entire function, the way we are sitting, seeing, thinking, breathing, the way heart, kidney, everything, the way it's functioning, it depends on the sequence. Okay. So DNA has a sequence. So there are multiple triplets called codons, okay, which is nothing but a combination of three nucleotides. For example, this TAC codes for an amino acid called tyrosine. Like that, when there are multiple codons combined together, they synthesize different amino acids. And when these amino acids join together, they form a functional proteins. So which are responsible to execute almost all the functions in the body, starting from thinking to all the motor things what we do. So there are different types of mutations which can happen. So, for example, if you take this genetic code, if you take this first codon TAC, if there is a substitution, let's say this thymidine is replaced by adenine, that is T is replaced by A, the TAC will be read as AAC, which may code for a different amino acid. That is called substitution. We call it as an insertion. See, this TAC is still there, but there is one more T which is getting added. That will also change the way the code is being read. Instead of TAC, it will be read as TTA. So there is a deletion. Again, the same problem. The TAC, the T is deleted. So this will the primer will think the A is the first one, and it will be read as ACG. So that is the kind of impact what it can have. Such a small change can result in a major functional change in any of the organ in our body. So whenever the gene is functioning optimally, we have a very good functional protein. If there is a mutation, it will produce an altered protein. The mutation, if severe enough, it will not produce any protein at all. So these proteins could be anything. It could be enzymes, these are synaptic vesicles, receptors, anything. So resulting in the disease manifestation. Clear? Fine. So there are different types of mutation which I briefly described in my previous talk the other day. In dominant mutations, only one defective gene from any of the parent is enough to manifest the disease. In recessive conditions, we need a defective gene from each parent to manifest the disease. So if one gene is normal, another is defective, they become carriers. In X-linked recessive, that is also similar to autosomal recessive, but only difference here is the males, since they have only one X chromosome, they tend to manifest the disease even if there is one defective gene. Whether the females will become carrier, so because they have two X chromosome, unless they inherit two defective genes. So that's how it is. So the boys have more chance of manifesting the disease, and most of these X-linked disorders will be severe also. I'll tell you why when I come to case examples. So now I would just brief you about the mutations like substitution, deletion, insertion, and all that. Let's see what impact these can have. For example, we call a mutation as silent if there is no effect on the protein sequence. Let's see. See, for example, this GTA is supposed to code for an amino acid valine. Let's say this A is replaced by T. So the GTA will become GTT. That will also code for valine. So eventually there is no effect on the protein sequence. This is called the silent mutation. The next one is the missense mutation, which results in an amino acid substitution, which can result in different amino acid synthesis. For example, the CCC is supposed to synthesis proline. So if the C is replaced by A, it becomes ACC, which is supposed to synthesize threonine. It may have an effect on the protein function. The other one is a nonsense mutation, when a nucleotide is replaced by such a nucleotide so that instead of coding, it becomes a stop codon. See here, the TAC is supposed to code for tyrosine. If the C is replaced by G, TAG is a stop codon. So that means it will become a stop codon. There will be premature termination of truncation of protein synthesis, resulting in disease manifestation. So, and one more important thing to remember is in DNA, we have, there are two parts. One is called exon, another is called intron. Exons are the one which are the coding region, which eventually undergo the transcription to result in mRNA, and also the protein synthesis, which is a central dogma of biology. So there is a process called splicing which happens in which the introns, which are the non-coding region, are supposed to be spliced. Let's say normal splicing, what happens? This is an exon 1, exon 2, exon 3, and there is an intron, which is the small line. If there is a normal splicing, this exon 1, 2, 3 will join. If there is a skipping, okay, instead of splicing these two introns, sometimes this it may happen in such a way, it may take out this exon 2 itself, and the exon 1 and exon 3 will be joining, and one of the exons and the corresponding amino acids will be missing. Similar way, there could be intron inclusion, and also there will be partial exon splicing, the partial intron inclusion. All these combinations are possible. What we call it as cryptic splice site mutation, intron inclusion, exon skipping, and all that. So whenever read a genetic test report, all these things becomes very important. Now, genetic diagnosis definitely is a pillar of precision medicine because we know we are moving from a generalized medicine to personalized medicine because patients are very demanding. They want everything to be very specific. They want to get to the root of the disease. So it's definitely helps to confirm the diagnosis, correlate with identify variants, and also determine eligibility for clinical trials because we know there are multiple genetic gene therapy trials which are going on, and sometimes it also helps us to refine the prognosis in some case scenarios. So far, there are more than 300 genes have been described which are known to cause IRDs. And also, just because someone has mutation may not manifest to the same extent. So there could be variation because depending on the epigenetic factors, systemic factors, and also environmental factors which influence a disease manifestation. Fine. So, and also it's important to know there is some healthcare professionals called genetic counselor or extremely important in case if you are in your clinic, if you are handling, genetic disorders. So these are allied healthcare professionals who are certified and licensed to obtain detailed genetic focused medical and family history and also critically evaluate and interpret the genetic testing result and also to educate the patients. So it's very important to have them in your team because they will save a lot of time because what happens is in your busy clinic and all that you may not have time to do all these things, and these people are certified, so you can just hire. And how to choose a genetic testing? There are different types of tests which are available: the next generation sequencing, microarray, karyotype. So NGS has got the highest coverage and the highest sensitivity. It can detect all these, whatever I described, like missense, insertion, nonsense, splice site variation, and all that. In that also, there are three types because like we have a patient who has suspected genetic testing, you need to write something, right? To what is the thing? Either you can write a clinical exome sequencing, which covers the protein coding region of around 6,000 genes, which are known to cause human disease, not only eye, everything. That's very important. In whole exome sequencing, as the name suggests, all the genes, all the coding region is covered. In whole genome sequencing, both coding and non-coding region will be covered. In microRNA array and MLPA technique, we do this rarely to detect any there is a duplication or deletion. And the karyotype is the basics what we have learned during our undergraduate days. This can detect only the chromosomal abnormality. It's got a very low cost and but sequence resolution is also very less because it can pick up only the gross changes. Fine. So these are all the symbols which are used when you draw a pedigree chart. It's extremely important. You need to teach this to your optometrist or assistant who can draw the pedigree before they meet you. That saves a lot of time. So these symbols are self-explanatory. Males are represented by square, females by circle. If there is consanguineous marriage, we draw two lines, otherwise only single line. So this Roman numerals represents the generation and Arabic numerals represents individuals within a generation. So this is how an identical twins and a fraternal twins are represented. If the person is affected, we draw it with the black shade. If it is affected just based on the history, just draw a cross line. Once it is confirmed, we can go back and make it dark black. And if a female is pregnant and is suspected to be a carrier, if it's not even pregnant, then also she can be a carrier. Then this is how it is represented. So if there's a deceased persons in the family, you can just try a cross line. If the sex is unknown, you can just draw this rhomboid. So these are different types of inheritance which you can make out from this. only males are getting affected, it's likely to be explained. If multiple family members are affected, it's dominant. If the parents are, consanguineously married, and if they don't have the disease, if children are manifesting, it's likely to be a recessive disease. So, whenever you subject a patient for genetic testing, informed consent is very significant because it has got a legal and ethical consideration. And individual receiving the genetic testing should be informed of the risk of incidental and uncertain findings, and the protection and limitations of genetic information non-discrimination act should be explained. And for genetic testing, you can use either blood, buccal saliva, or, buccal scraping, saliva, or skin fibroblast. Basically, they need some cells to extract the DNA and to detect the gene analysis. So, for interpreting genetic testing, we use something called ACMG guidelines or American College of Medical Genetics, just set forth these guidelines. And most testing labs use these guidelines for interpretation and reporting. Once you get the report, there are multiple online resources like ClinVar, Genome, Franklin. So basically, ClinVar, it compares the variant classification with other laboratories. In Genomad database, there's an exome and genome data individual from individual from across the globe. In Franklin, it combines both the thing, which is an AI-based platform, which is becoming quite popular these days. You can use any of these online resources. Whenever you do a genetic testing, it's very important to remember that it's not like checking for HbA1c or CBC. Most of the time, you may get some inconclusive results, in which case, analyzing a classification of points around the VUS or examining the other family members or offspring can help to clarify this VUS in recessive genes. And positive genetic test results may reveal some pathogenic or likely pathogenic variants and should be analyzed in the context of clinical findings, because just because you are getting some mutation, you should not label that that is the responsible gene. For example, in this case, it's a very mild Stargardt's. ABCA4 is the gene which can cause Stargardt's. Here there are two mutations, one in exon 18 and one in the exon 48. We call it as compound heterozygous. In that, only one is reported as pathogenic, and we also know that the disease is mild. So this is the likely cause of the disease. So that is in brief. So when we do a genetic testing, incidentally, we end up, detecting a gene which is known to cause some other systemic problem, like some of the gene, they may come for eye problem. They may known to cause some heart conduction block. In those cases, you need to refer to a concerned specialist. And genetic counseling is important to understand, make them understand the inheritance pattern, availability of preconception and prenatal genetic screening, also to address the psychosocial factors. So I'll just end with this case example. I'm just not going to the details of this gene. This RPGR gene is known to cause something called retinitis pigmentosa. So this was a 3-year-old male child with gross blurring of vision. If you see the fundus, there's a bone spicule-like pigmentation, but unfortunately the macula is also atrophied. It's quite a severe disease for a 3-year-old child. So this is the corresponding autofluorescence, which can better highlight the atrophic areas, whatever I showed in color fundus photograph. And like this is the corresponding OCT showing extensive degenerative outer retinal and also pigmentary degenerative changes. So this was the pedigree when she came. Someone had told, had diagnosed the mother also to be having the same disease, and grandfather also lost vision early because of some eye problem. So this was the genetic test report what the mother was carrying. If you see, there are multiple genes what we got in a report. There is a ROM1, which is also known to cause autosomal dominant retinitis pigmentosa, RPGR, which is again known to cause X-linked retinitis pigmentosa. There is one more gene called ZNF408, which they have reported as it's of uncertain significance. Now, how to zero in on which is the gene responsible here? So I just wanted to examine the mother first, just to be very sure what problem she has. When I examine the mother, this is the autofluorescence. There are just the background autofluorescence changes. When you did the OCT, the retinal layers were quite intact. There were no degenerative changes. So this is a typical carrier status. Okay. So this is the picture of the mother and the son. Mother is just a carrier. Son seems to be affected severely. And now this is the correct pedigree. So mother is not affected. She's the carrier. The grandfather is likely to have affected. We have not seen him. It's just based on the history. Now coming back to the genetic testing again. If you look at the ROM1, it is an autosomal dominant. It is present in mother, but it's not manifesting the disease. It is unlikely. But if you look at the RPGR, So I'll just take 1 minute. It is heterozygous X-linked and it fits very well. The mother is a carrier and the son is manifesting a severe disease and the son being a male only and one X chromosome manifesting a severe disease. So this is the most likely gene. And when you did the testing in the son and the father, we got the same gene. That's how we deduce it. To conclude, I would like to say genetic testing is the blueprint of life, guiding development, function, and inheritance. So, this DNA, which gives genes, proteins, traits, which form the central dogma of molecular biology. So, understanding the basics gene is very extremely important. It doesn't matter whether it's an ophthalmologist, retina specialist, or any other specialty. You need the way things are advancing. You need to know about the basics of genetics. So, because as I was telling, it's not only for the individual variation, and it's the foundation for personalized medicine, which is going to be the futures. We've come a long ways from Mendel's, the piece what he used to a modern genomics. And to end, genetics is not just about studying genes, it's about understanding the life itself. So if any of you come across any of the genetic disorder, if you have any problem, you can always get in touch with us. You can note down these numbers, take a screenshot. Thank you so much.
Thank you so much, sir, for this comprehensive coverage of this topic. And I'm sure the students will benefit a lot, especially about the pedigree analysis that you stressed about and the case studies. That was really good. Any pointers would you like to add for the residents for any case based on genetics in their examinations? Like in oral viva, they are asked some
Yeah.
question, what should they stress on?
So whatever I described, they may get a question in recent advances. You need to answer there. The second thing is in your exam, you are most likely to get a case of retinitis pigmentosa, where they may ask questions related to genetics. And also sometimes some of you, if you appear for FRCS exam, there so definitely they will ask these days. I've been a coordinator for FRCS. So there, when you don't go very deep into the genetics, okay. So only when you like, for example, if you got a case of retinitis pigmentosa, what you need to stress on how to draw a pedigree in this, how to make sure that you draw a pedigree in that patient, and the genetic testing, what type of test you advise, the way I showed, and how do you interpret the results of a test when given it. If you answer these three things, it is more than enough. So in FRCS exam, depending on the case what you got, they may go little deep. Like for example, X-linked, dominant, recessive, what is the severity and what's the type of mutation. That they will ask only if you have answered other things well. They will not directly go and ask you about the genetics. This is just to give maybe some extra marks.
Thank you so much, sir. So moving on to the next speaker, there's a slight sequence change. Dr. Niranjan Karthik will be talking about his topic, which is medical legal aspects of ophthalmology. Dr. Niranjan, are you here?
Yes, Dr. Gunjan.
You may
Thank you so
start
much.
your presentation.
At the outset, I would like to thank Professor Sir and the entire organizing team for having me here. So let me quickly share my screen and we can get going. So I hope my screen's visible and I'm audible. Yes,
Yes, very well.
right. A warm welcome, the good evening. So today we are here to discuss about the medical legal aspects in ophthalmology from the PG exam perspective. And just like the previous speaker mentioned, it forms a very integral part of today's practice, starting from genetic counseling to even the most common procedures that we do. So it's quite important that we are well informed about the same. And, as postgraduates, it should become, or it already is, a part of our curriculum that is expected to be trained, right? So I have had a very exam-oriented perspective to this talk. So I'm just going to share a few possible questions which may appear, like Sir was mentioning. These may be the questions which can give you those extra marks in your exams, which others may not be in a very good position to answer, be it theory or viva. So means you have only this question to answer left in your theory paper, or in your viva exam. Probably you fared quite well, and this is going to give you the icing on the cake, I bet. So among these questions, I've highlighted a few in purple, which have even more chance of appearing in your exams in one form or the other. So this is about the short notes, and they are quite important because they have certain sections in our legal framework associated with them, right? And some of them, like Sir mentioned, can be a feature of the recent advances like teleophthalmology and its medical legal challenges, which is quite vast. I'll try my best to cover the basics in my given stipulated time and uh, just open up the discussion for you to maybe work on it a bit more. So these are some aspects or this list of questions that you may expect. So I request you to take a screenshot if you would like. So with that introduction, let me quickly start off with some core concepts, starting with medical negligence, which is what is the hot topic of the hour from the medical legal perspective. So it is basically defined as a breach of duty of care by doctor resulting in damage to the patient, and that a reasonably competent doctor would not have committed under similar circumstances. Now, each part of this definition becomes crucial, which is what is picturized or portrayed in the the Pixart you are seeing here. So the four Ds are very crucial to label an act as medically negligent. So starting with D for damage, yes, the patient should have undergone some injury or damage. There exists a duty of care. Now that is important. So any doctor cannot be randomly penalized just because he was on the floor. There should be an established connection between the doctor and the patient owing the duty of care to the patient. And then comes the third D, which is dereliction or breach of duty. And finally comes the direct causation, right? So it is of paramount importance that all these factors are present in the case to proceed any further. So some scenarios which one may get or one may face in their practice would be wrong power of the IOL, wrong surgery on the surgery on the wrong eye, missed diagnosis, right? Poor asepsis resulting in endophthalmitis, inadequate follow-up, poor selection of patients for LASIK. So each subspecialty has its own set of legal scenarios that they may expect to face. Now, what are all the legal consequences? Even till date, we receive so many notifications about the Consumer Protection Act, right? So there is a lot of hue and cry going on about whether the services rendered by the medical fraternity should fall under the COPRA. So that is still a matter of debate. But having said that, at least till date, it does fall under that category. So we are people who deliver services to consumers, right? Which are who are the patients. So there exists an element of compensation in case things go wrong. Professional misconduct proceedings are possible. However, in our field of ophthalmology, criminal liability is quite rare unless it is gross negligence and things like that. So, how do we bypass or how do we avoid such scenarios? Get your consent proper. Communication is the key. Documentation is the pillar, and standard treatment protocols should be adhered to. And last but not the least, have your professional indemnity insurance intact. Now, coming to the second important topic, informed consent. And this topic cannot be stressed more, right? The definition itself stands to speak. Voluntary permission given by a competent patient after understanding the nature, risk, benefits, and alternatives of a procedure. Now, again, like in any definition, each word here matters. So all of it should be, ticked before we proceed further with any procedure. So the essential components has been listed out again. So, like I mentioned, a competent patient, right? He should not be mentally, in a situation where he cannot give the consent and things like that. So, all of these, an adequate disclosure, mentioning all the complications. The decision should be totally voluntary and not coerced. And finally, all in written documentation, right? So now, looking at the types of consent. Now, these are questions which can feature in your Viva, right? So, types of consent. If at all you answer all your basics right, and then the examiner wants to test you from a practical standpoint, right? They ask you, so now a patient comes to you and you take the liberty of examining the patient's eye by touching the lids and opening them up. So, have you taken the consent? That is where comes the implied consent. So that means when the patient walks into your OPD, it goes implied under quotes that he or she agrees or allows you to do certain basic examination, right? There is the implied. Then comes the express consent, which is the oral or the written consent. Now, Informed consent is not the same as oral or written consent. Just because a paper is signed by the patient doesn't mean anything in the court of law. Informed basically means the patient should have understood what he or she is being subjected to. And then comes proxy consent, which is often given in cases where they are mentally unstable or it's a minor that is in question. So going ahead with the informed consent, each procedure has its detailed version. So that has to be totally fulfilled. High risk procedures, like in cases of one-eyed status, require a separate written consent, right? It cannot just be considered under the universal consent for that particular procedure too. And what are the common errors that one may expect to occur in consent? First, generic consent forms are not the order of the day. So in the court of law, it has to be particularly tailored for that procedure, meaning just a blanket statement saying that I am willing to undergo this procedure is not going to help. If it is cataract, if it is of a particular type, all that has to be featured in the consent. The complications not being mentioned and just saying that I am willing to face the complications is not going to help. You have to at least enumerate the most common ones in that consent to proceed any further. Language not being understood by the patient is a major area to be addressed because uh, the consent being made available in a linguistically compatible format is of paramount importance. Now, what happens? What happens if we don't do this? Medico-legally, no consent basically means assault. What is assault? It is primarily defined under the section 130 of BNS, which is Bharatiya Nyaya Sanhita, which is the recent or the modified version of Indian Penal Code, right? Covers any gesture, what to speak of a surgery, any gesture or preparations causing fear of impending criminal force. There is not even an existing or an established force. Even impending criminal force resulting in fear amounts to assault. Now that shows the gravity of the situation. And of course, when this consent is not there, comes the term negligence yet again. So let me give you this clinical scenario, which is a situation where only papers save the doctors. So endophthalmitis, whether to be deemed a negligence or complication, is all decided not by the act or the organism, but by the papers. So it is, of course, a known complication of cataract surgery. The question is it negligent or not? And it is not negligent if standard aseptic precautions were followed, proper consent was taken, and prompt diagnosis and management was done. And all these have been documented. That is important. Now, one may ask, how do we document aseptic precautions? We have Bovidic indicators which are to be filed and maintained in a register. Proper consent, yes, that part I think all of us are clear that we should maintain it in the IPK sheet. And then how do we manage? We should have a documented evidence of a B scan showing vitreous X-ray, right? Hyperechoic reflective echoes seen in the B scan in the vitreous cavity. So all of these should be there as a part of our documentation when we appear in the court of law. So like I mentioned, documentation decides the eventual outcome, the medico-legal outcome, even if not the clinical outcome. Now coming to the wrong IOL surgery or the wrong eye surgery. Now these are things which are not pardonable. So we've all learned it in our forensic medicine in our undergraduation, rapes or located, where the thing speaks for itself. So it has a strong penalization under the Consumer Protection Act, and this is usually dealt with quite seriously. And even in such scenarios, it is important to have the rest of the documentation right to save or limit or reduce the penalization. Now, as you can see on the right, the criminal negligence is something that defines the punishment that is being applied to people who have uh, had to be prosecuted under this section. So, for a registered medical practitioner, that is may not be applying to ophthalmologists, but in general, an RMP, any death that occurs due to negligent act can even extend up to 2 years and a heavy fine. And now, coming to why and how this COPRA changes the game for the doctors. It defines service, medical consultation, diagnosis, treatment, both medical or surgical. All of this fall under the big umbrella of services under the Section 2 of 2019 COPRA Act. Now, these are exempted only and only if they are rendered completely free of charge to everyone under a contract of personal or under a contract of personal service. Now, there is an important catch in this. Let us say in a hospital where there is a mix of patients. For certain patients under the camp, we do it free, whereas some patients are being charged for their premium IOLs and whatnot. In that case, even if you're operating these people for free, they also fall under the umbrella of COPRA. So it is crucial for us to understand this concept to avoid any medical legal implications. Then moving on to ocular trauma, again a very crucial area where comes the legal definition of grievous injury. This again can be your Viva question, right? So they are classified as grievous hurt if there is permanent loss of vision. Now again, there are a lot of ifs and buts in this when we talk about it. Like let us say there's traumatic cataract. Now it is because of trauma, but once you remove the cataract, the blindness or the partial blindness gets, corrected, then does it come under grievous hurt? Doesn't come under, because it's not permanent, right? So uncorrected or incorrectable, that's the better way to put it. The best corrected visual acuity reducing after injury is what matters, right? So grievous injury is defined as by the section 116 of BNS, where it says 7 different categories, which we've learned it in medical legal aspects in forensic, of which permanent loss of vision is where we come into the picture. Last part, ophthalmologists, we are expected to be multidimensional, and so are we expected to be witnesses, right? And these are expert witnesses. So various clinical scenarios include claims of compensation in cases of injury, may not be grievous hurt from our side, but happening elsewhere, and we have to certify. Our views in cases of disability, and finally representing a scientific body to testify in case of negligence. So this is an article that was published in our esteemed journal IJO, where we see that the place of the ocular injuries are very common at workplace, and making that a very potential area for asking for compensations, right? And as you can see in this excerpt from that article, the place of injury, or about 3% of the whole injuries, were actually in their workplace, 3 plus 2, that is around 5%. So it is important for us to establish a causal relationship between the severity of the injury and the causation of that injury to that incident. And finally, we have to certify them as to what is the extent of vision loss. So this is how the claims of compensation works under the Employee Compensation Act of 1923. So under this, the fourth category says loss of sight to such an extent as to render the person unable to perform any work for which eyesight is essential, right? So that gives a 10% loss of earning capacity, making them eligible for compensation. Now, coming to the disability benefits, again, we are expected to certify them for disability. Here comes the concept of benchmark disability, where there are certain exclusive benefits if they are eligible under this category, including occupation in certain sectors and so on. So, touching upon this aspect of RPWD, the Rights of Persons with Disabilities Act, right? So in this, there are two important things that one must remember. First is the category of physical disability, where loss of sensations in the hands or feet, as well as loss of sensation and paresis in the eye and eyelid, even without a manifest deformity, accounts to physical disability. Point number one. Number two comes the visual impairment, which is an obvious category, but that again has two subdivisions to it. First is the blindness part, where there are these categories, right? So total absence of light, visual acuity less than 3 by 60, limitation of field of vision. Beyond that is the low vision category, where the visual acuity is not exceeding 6 by 60, 6 by 18, or there is a limitation of visual field of about less than 40 degrees, but more than 10 degrees. So this is how the impairment of vision has been classified into low vision and blindness. So it is important for us to be aware of this. And finally comes the testimony in cases of negligence. It is very interesting point to note here that among the cases received in the Consumer Dispute Redressal Commission, this is the exact point that I was trying to tell you. Since our services fall under the umbrella of COPRA, we are being subjected to NCDRC, right? Among the 942 cases of medical negligence that were decided between the period of 2002 and 18, 30 were related to ophthalmology, right? Among the 30 cases, 73%, right, were proved, and compensation for the cases ranged between 2 lakh to 10 million, which is about a crore. So there is quite a significant proportion of litigations against us, and we must be aware of it. So to conclude, take home points: most medical legal disputes are preventable and arise from deficiencies in documentation, consent, communication. Medical records are the best legal defense, and what is not documented is presumed to not have occurred. Informed consent must be procedure specific, adequately disclosed, and understood by a patient. A mere signature is legally insufficient. And lastly, liability is determined by adherence to the accepted standard of care and timely documented. So, with that, I would like to thank each and everybody for giving me this opportunity. I hope this was a useful talk for all the postgrads. Thank you.
It was a wonderful talk, Dr. Niranjan. Next,
Thank you. Thank you.
I would like to invite Dr. Gunjan Buddhiraja for clinical approach to a red eye. Over to you, ma'am.
Yes. Yes. Is my screen visible?
Yes, ma'am. Please go ahead.
Yeah. So, good evening, all. I'm talking about pink eye, which is a practical approach for ophthalmologists. Sorry. Yeah. So, I'll be discussing few cases here, and it will be little bit of MCQ based approach for all the listeners. So, just a second. Give me a second. Yes. My screen is visible right now.
Yes, ma'am, it's visible.
Okay. Okay. So I'm just showing this as the starting point because I want you all to look at these all pictures and find out which is the odd one out here. So if anybody in the audience can answer, you can put it in the chat boxes. I'll just give one second and then I'll just talk about the following picture. So these are A, B, C, and D. These are all movies, and they have one thing in common except for one of the movie. So here, if I'm showing all of this, this is pink in all the three titles except for the fourth title, which is Barbie, but we can still associate it with pink. So why I'm talking about this is because the pink eye can have different variations and it is just not pink because we have to look at all the conditions that are associated with the pink eye. So by the end of this session, we'll talk about what are the classifications of conjunctivitis, and then we should be able to differentiate between viral, bacterial, and allergic conjunctivitis clinically, and also recognize the red flags and vision-threatening conditions, and then initiate the appropriate management because this is very important in cases of pink eye. We can be sure about all the diagnosis, and then only we can give particular treatment because we may miss out a lot of pointers and the patient may not get clinically well. And one more important point that is really, really important in finding out the emergency cases that we have to find out when we have to refer these patients and we have to start any urgent treatment if it is required. So all the red eye patients are not conjunctivitis, and we have to always rule out any corneal and intracorneal in the intraocular pathology. So that is what we'll be talking about. Before that, I'll just discuss about briefly about the conjunctival anatomy. There are two parts mainly, which is palpebral and bulbar conjunctiva, and these are cornices. So we have to first find out uh, anatomically because we need to start our treatment based on different parameters and where the redness is. So these are the differential things that we are going to talk about the palpebral conjunctiva, bulbar conjunctiva, and there are different modalities that I'll be discussing in the coming pictures. So one thing that I will discuss is inflammatory and inflammatory, non-infectious, and infectious rednesses of the eyes. So where one is the inflammation of the conjunctiva, which is called conjunctivitis, which is characterized by hyperemia, discharge, ocular irritation, and this can be both infectious or non-infectious as well. So, infections, we can have viral, bacterial, and even sometimes we have parasitic infestations as well, which is very rare. And non-infectious, we can have allergic or toxic or irritative rednesses or pink eye, in other words. So this is the relevant anatomy that we need to know, and these are the questions that may be asked in your examination, especially diagrammatic representation of the histopathology. And the goblet cells also are important to know in conjunctiva because these are related to the mucin layer formation. And also we have to talk about the rich lymphatic drainage because we have to associate this with preocular nodes, especially in cases of viral conjunctivitis. Also, you can take a picture of this to be used for your examination preparations and revisions because this will form as a good viva question in some patients. In some questions, they may be asking you about different types of epithelium and also these kind of follicles, papillae, etc. They can ask you. And it's a very important question also that what are the layers of conjunctiva is a diagrammatic representation that may be asked during your examinations in written as well and sometimes in viva too. So as I talked about the question of follicles, papillae, this is really important and you need to talk about this in viva a lot of times. Also, you need to know about the immune barrier that is present in conjunctiva and mold, etc. You can talk, you can read in your books. It's very widely written and it's very important as well. So, what should be the red eye approach? First of all, you should always check vision. Sometimes in patients who are very symptomatic, you may not be able to take vision properly, but this is really important and medico-legally also sometimes it is really important as we looked at in Dr. Ranjan's talk. And second could be that you should look for pain and photophobia. That is also really important because sometimes the corneal involvement may be ignored. And that is what we have to take care when we are looking at a patient of red eye and not ignore any corneal signs too. And you have to see that if there is some discharge and itching, especially in children, they may have other foreign bodies too, which may be ignored in just thinking that this may be a clear-cut case of allergic conjunctivitis and you may miss out a lot of things that you had to see that is maybe they had some foreign body embedded so you have to clearly check everything when you're seeing or examining a case of conjunctivitis or red eye. So if you decide after the checkup that this is a simple conjunctivitis then you need to treat them and if you see some red flags you have to refer them urgently. So this is one picture that I want to show here. If some audience wants to answer it, and you can put in the chat box. So this what could be the diagnosis of this picture? I'll just give you 1-2 seconds to think. So, okay. So this is a case of subconjunctival hemorrhage. You may be seeing these patients a lot coming as emergency and panicked because the patients sometimes think that it has been a very big problem and they just want to check up whether this is something related to the blindness or something else after trauma, especially. So there are various causes of subconjunctival hemorrhage, and the most commonly sometimes is ocular trauma or increased blood pressure and in some patients, it may be related to any long-standing cough or constipation. Could be also related to bleeding disorders. So you may need to get BTCT in some patients. Also, sometimes during very heavy menorrhagia, etc., patients, especially female patients, they have subconjunctival hemorrhage during their menstruation period. So you have to ask the correct history too and sometimes in elderly patients, they may have spontaneous rupture of the fragile capillaries in diabetics as well. So this is a very small case that may be asked as for diagnosis in your examination as well. As I talked about follicles and papillae, this slide is a very important slide because you may be asked a question in either written form or viva because we have to know the anatomy of follicles and papilla, which is this yellowish white multiple discrete round elevations are follicles and they are encircled by tiny blood vessels. So there is a very good diagram that has been given in your textbooks. You should always practice this because sometimes you may need to draw it and it's a very scoring examination question. So you may always get good marks for this because follicles and papillae sometimes may be asked in your examinations. So the follicular reaction, the anatomy is related here because in patients with viral conjunctivitis and chlamydia, you may have the involvement of follicles, and also in some patients with hypersensitivity to topical medications. And this is related because here it is due to the localized aggregation of lymphocytes. So this is why it is really important to know the anatomy so that you can, talk about patients who are having viral conjunctivitis, etc. In papillary reaction, there is appearance of capillaries which are growing into epithelium, and it is very commonly seen in bacterial, allergic, and contact lens wear patients, and superior limbic keratoconjunctivitis, which is associated with thyroid patients. So this is important to know because papillae have been are present in upper palpebral conjunctiva, and also they are attached to a very deep fibrous layer. So this is important, and this viva question is very common. So there is infective conjunctivitis, as I already talked about, bacterial, viral, chlamydial, and non-infectious conjunctivitis. This is a whole list you should be knowing about it to write in examination as well. So the types of bacterial conjunctivitis are acute, hyperacute, and chronic. In bacterial conjunctivitis, this is a slide that shows different organisms that are associated with bacterial conjunctivitis, which is Staph aureus, Staph pneumoniae, Haemophilus influenzae, Neisseria gonorrhea. You should know all the features of these conjunctivitis, and you should also know which are gram positive and gram negative because you need to know the correct antibiotics that are useful in these patients. This is important to discuss because this is a pseudomembranous conjunctivitis, and why it is important because you can see here there's a pseudomembrane formation, and this is related because we need to sometimes remove these pseudomembranes in getting a great result in clinics. And it is basically a type 1 sensitivity hypersensitivity reaction which is IgE mediated, and patients may also have intense itching and chronic red eye which is not getting better. It can have different variants as well, and there is conjunctivitis which is involved, which needs to be tackled well with antibiotics. And you can read this completely. Okay, presentations are written in your books. You can always discuss with your seniors as well during the clinics because these are very common during the conjunctivitis season. So this coming to allergic conjunctivitis, here you can see that I'm really sorry. Yeah, so there is one case which I'm going to discuss. This is a 10-year-old boy who presents with severe bilateral ocular itching and thick ropey discharge photophobia, which worsens after every spring. And this examination reveals the distinct findings of giant papillae hornet ranta spot, sheet ulcer, and also Giemsa stain shows eosinophilia. So any answers in the audience, you can answer in the chat box. Giving you 1 second. So the correct answer is vernal keratoconjunctivitis, which is a type 1 IgE mediated hypersensitivity reaction. And this slide is really important because these are all the signs that can be asked in Viva question 2. This is one more question that is which is here related to vernal keratoconjunctivitis, and this is a cobblestone appearance. This is also a spot diagnosis. Sometimes can be asked in and small cases, short cases in your Viva question. So you need to know about the cobblestone appearance and the histological basis of these papillae. So this is the composition of the cobblestone papilla. That is, it has a microvasculature and is a central vascular core, and there is a mast cell as well. So the one is first is your hypertrophied conjunctival epithelium. Then you have these stromal proliferation and infiltration here, which is composed of mononuclear and eosinophil infiltration, and then mast cells. So this is also a very important diagram that can be used in during your writing the answers of these patients. Okay, so before that, I'll just discuss about viral keratitis also in the infectious cases. This is also a very important slide because the different kind of viral keratitis, there are epithelial herpetic keratitis, stromal herpetic keratitis, and deciform keratitis, and endothelial keratopathy. So this is important because heads trial is really important and is the most commonly asked question when you get a viral keratitis case in your either theory or your practical examination. And you can take a picture of this slide. This is written very nicely. So here you can find out heads 1 and heads 2 recommendations accordingly. And you have to one more thing that is very commonly asked is which one is immune mediated and which one has the active live virus, and this is sometimes very commonly asked. And this is a very good diagram that is given in Kratchmer. You can read from the table given there. And the live virus question is commonly asked, so you need to know all these questions by heart. Now coming on to episcleritis, which is a non-infectious cause of redness. So what could be episcleritis? This is inflammation of the episclera that is there. So the different laboratory tests that are asked are ASR, CSR, CBC, sorry, rheumatoid, ANA, uric acid, BDRL. Sorry, give me a second. Sorry. Sorry for the glitch. Am I audible?
Yes.
Yeah. Okay. So. So in episcleritis, there can be little bit of redness, but in scleritis, it can be reddish or blue as well. This is an important pointer that in episcleritis, it blanches with phenylephrine, but in scleritis does not blanch with phenylephrine. And episcleritis usually self-resolves, and there can be some cases of recurrences too. Is my screen visible?
Yes, ma'am, it's visible.
Okay. So, this is the scleritis grading that is seen here in the slide, and you can take the picture for this. And this is very important. Sometimes you can be asked in the question in theory as well. So, now we coming to the viral conjunctivitis again. Here, it's important because in some patients who have viral conjunctivitis, sometimes antibiotics do not help, and you need to find out adenoviral association as well. And in this, we have to look at the lymph nodes too. When we are looking at the patient, we need to take the relevant history also with association with URI as well. So the differential diagnosis of the redness in the eye can be classified into episcleritis, scleritis, conjunctivitis, uveitis, and pindiculitis too. So the differential diagnosis are already discussed between episcleritis, scleritis. Now, uveitis also you need to see in a lot of patients. So you have to first look at the slit lamp and look at cells in the anterior chamber and ciliary flush. Pindiculitis you can obviously differentiate very well on the slit lamp. So these patients may show different kind of uh, existence because they are over the pre-existing conjunctival degenerations too. So the different uveitis that are seen are different anterior uveitis, intermediate uveitis, posterior uveitis, and if all the layers are involved, then this is called panuveitis. So you can read about different uveitis as the time is very short. I'll just touch them on the topic. So the summary of various causes is here. You can take a snapshot of this and keep it as a pearl to revise before your examinations, so that you have all the differentials at one place. The red flags that we have to always look at is the emergency that can be there in redness. One is keratitis, uveitis, angle closure. Acute angle closure glaucoma is one of the most common differentials that we need to look at as a red flag, because sometimes we may miss out a lot of patients reporting with these problems. So the diagnostic approach would be that first we need to see the visual acuity. Is it unilateral, bilateral? And if there's any discharge association, if there's no discharge, then you need to look at either it's a viral conjunctivitis or other non-infectious conjunctivitis. And follicles papillae has to be seen. You have to palpate the preocular nodes and also stain your cornea nicely with fluorescent so as to not miss out any cornea related problems too. And if possible, measure IOP. If not, then sometimes it's better to not measure IOP because of fear of spread of infection and also the discomfort to the patient. So, if you have to talk about conjunctivitis, it can be most commonly viral associated, but not always. But still, viral should be your first differential in patients who are not having any discharge. If it is itching, then allergic conjunctivitis may be there. If there is hyper acute purulent conjunctivitis, then gonococcal is also very, very common. We have to look at the history and rule out those differentials too. If there is a reduced vision, then it is not a simple conjunctivitis. You need to look at epidemic viral conjunctivitis always. And always stain the cornea in unilateral red eye. It's important. Thank you so much. And I would be happy to take any questions from your side.
I think there are no questions, ma'am. Thank you for a very wonderful insight on management of red eye, a good clinical approach with all the algorithms. Do we have Dr. Bhavna Chawla here, ma'am? Dr. Bhavna, ma'am. Dr. Sumit Grover. Well, so we need to move on to the star of keratoplasty, Dr. Madhuvanti Mohan from Chennai. She'll be talking about the keratoplasty basics.
I don't think I'm the star of keratoplasty, but I'll talk about it. Just before I start, I'm sorry to the rest of the speakers. Please keep the talks under 10 minutes. I know it's difficult, but I just would like to say it once here. Okay, so I'll just be sharing my screen. Give me a second.
Your screen is visible. Go ahead.
Yeah, just give me a second. Sorry. Is it still visible?
No, not right now.
No. Okay, once again. It's visible, right?
Yes, it is visible right now.
Okay, thank you. Good evening, everyone. I'm going to be talking about the basics of keratoplasty today. So we all know it is a technique of performing a full thickness corneal transplantation where a diseased cornea is removed and replaced with a healthy, viable donor corneal tissue. And it is one of the first procedures taught to cornea fellows during fellowship training also. So the main goals of keratoplasty is to restore transparency, restore any tectonic integrity if necessary, and to improve visual function. Today, I'll be focusing mainly on penetrating keratoplasty because lamellar keratoplasties were covered largely during the cornea module. So, sorry, yeah. Yeah, so based on the thickness, keratoplasty can be divided into your full thickness penetrating keratoplasty, which can be optical, therapeutic, or tectonic, and your lamellar keratoplasty, which can be anterior or posterior lamellar. Anterior lamellar, depending on the depth, can be your superficial anterior lamellar or deep anterior lamellar, and posterior lamellar can be now with advent of many other procedures. Everybody knows DSEC and DMEC, but there is also PDEC and DSO. So so this is a photo which shows the different types of keratoplasties, and nowadays we see a shift from PK to more lamellar procedures being done, and most commonly DSEC is the most common surgery that is done nowadays. This is because lamellar procedures are preferred because of faster recovery and fewer complications. So before coming to the steps of the surgery, let's talk a little bit about indications. Patient selection is one of the most important steps before surgery, before any surgery as such. In optical PK, what we want to do is restore vision in cases specifically for scarred corneas with disorganized anterior chambers. Earlier, we used to do for even keratoconus, even pseudophakic, aphakic bullous keratopathy. But nowadays, we need to look for those which have a full thickness scars, any healed keratitis which has caused a full thickness scar. Earlier, it was done for Fuchs endothelial dystrophy also, but nowadays, it's lamellar is the main surgery for those. Next is therapeutic. In therapeutic, the main indication is removal of any infected corneal tissue, which is refractory to maximal medical therapy, or those which is involving the limbus or a very large infection. And tectonic in stromal thinning, desmetocele, any sterile perforations, and even sometimes ectatic disorders. So a thorough history is mandatory before going for surgery. So we need to know about a prior history of ocular infection, any prior surgery, trauma, chronic ocular surface disease, and any systemic comorbidities need to be documented. So it is important to assess the visual potential of the patient prior to the procedure because this tells us the visual prognosis of the patient post-procedure. Any lid pathologies need to be ruled out. The cornea should be assessed for extent, the degree of corneal opacity, along with any extent of corneal vascularization, whether superficial or deep, because that is important in keratoplasty, and presence of corneal sensations. So in the case of a previous graft, we want to note down the graft size, presence of any sutures, anterior chamber depth, presence of any anterior synechiae, pupillary dilatation, and the lens status must also be noted. So if you look into ocular factors, the previously failed grafts and multiple failures, they have a higher risk of higher risk keratoplasty. So more than 2 quadrants of deep vascularization is classified as a high risk graft. and other graft-related factors such as large grafts and eccentric grafts, which are closer to the limbus, they have a higher chance of failure. Now, like stated earlier, the lens status should also be noted, whether it is phakic, aphakic, or pseudophakic. Phakic patients might require a cataract extraction with IOL implantation at the same time, and aphakic patients may require an anterior vitrectomy, pupilloplasty, or a secondary IOL. So other investigations include your intraocular pressure measurement, retinal assessment, if the retina is not seen, an ultrasound B scan, and dry eye evaluation if required. ASOCT again can be done to assess the extent of the opacity, to delineate the opacity, and helps plan for whether the graft can be a full thickness or a lamellar graft. And in a few cases, ultrasound biomicroscopy may be required to look for the angle and ciliary body characteristics, especially in those where we are not able to see into the anterior chamber. So another preoperative evaluation is we need to assess the donor corneal tissue. So it is assessed both on slit lamp as well as on specular microscopy. This is done to document the endothelial cell count, and we need to label the tissue as whether it is fit for research, whether it can be used for wet lab, if the endothelial cell count is good enough for a lamellar or optical penetrating keratoplasty. So for an optical keratoplasty, the tissue should ideally be used within 48 hours, and the endothelial cell count should be at least more than 2000 cells. So the optimal time from death to recovery is less than 24 hours, and or up to 24 hours if the donor body has been refrigerated or if ice has been placed over the ice. Nowadays, most eye banks can even prepare pre-cut DSEC and DMEC tissues even after marking the S or F on the side to help in orientation. And this option of preloaded tissue has become increasingly utilized nowadays, especially abroad. So there are some contraindications for not using a donor graft. The main thing is to remember is to avoid in those patients with septicemia, there is any infection, any localized source of infection, also any malignancy or any death because of an unknown cause. And what kind of diseases can be transmitted from corneal transplantation? There's a list over here. Nowadays, we also add COVID or coronavirus into this. So another area of pre-op preparation is first, if the patient requires IOP control, we can give a mannitol prior to surgery. It decreases the vitreous volume so that there is no upthrust during the procedure. The effect usually becomes maximum after 30 minutes. So ideally, it should be given before initiating block. Some surgeons can even give it when putting the Fleringa ring. Pilocarpine can be given in patients with a clear lens so as not to traumatize the lens on trephination. And tropicamide can be given in those patients with cataracts if you're planning a triple procedure. So coming to anesthesia, local peribulbar anesthesia is usually the norm, but in certain cases, for example, pediatric patients or in uncooperative patients, or in case of perforated corneas, thin corneas, a significant infection, general anesthesia is preferred in those. So once we paint and drape the eye, the eyelids are separated using a speculum, and the best to use is a self-retaining speculum, which doesn't obstruct the surgical field. So now we'll talk about the steps of penetrating keratoplasty. And first is the application of a fixation ring. So Fleringa ring is the most commonly used fixation ring. It is available from a 12 to 23 mm in size. What we do is we take a minimum of 4 silk or vicryl sutures with a spatulated needle and apply it in a diamond configuration. It is usually used in hypotenuse eyes in pediatric patients, in aphakic or vitrectomized eyes, and usually by beginners. So ideal size of the ring is we want it to be at least 2 mm from the limbus, and it is mainly used to prevent collapse of the globe during surgery and allows for intraoperative manipulation without scleral collapse. A rare complication of this step can be scleral perforation with a retinal hole, which is managed with cryotherapy at the site of perforation. A fixation ring can also induce unwanted astigmatism. So next is the marking of the host cornea. So before we punch the donor corneal tissue, we want to mark the host tissue. See, optical axis can be marked by using a marking pen. And with the help of a caliper, we can measure the vertical and horizontal diameters to determine the size of the graft. And we wanted to encompass the opacified area, and ideal graft size would be 7.5 to 8 mm. For beginners, we can also use an RK marker as shown here, which can make suturing easier and make the sutures applied to be more radial. Coming to donor corneal preparation. So this is usually done under the microscope. I think it is better to be done under a microscope, although a lot of people do it under the naked eye, but it is better done under the microscope. So the donor corneal rim can be held with a conjunctival forceps. The rim is dried with a Vexel sponge, and not a normal bud, because we don't want any fibers on it, before placing it on the Teflon block. So once it is placed there, you can see here the punch is being applied, this one, and we punch with pressure downwards. Ideally, it is better to go in one go, as it minimizes damage to the endothelium. So we cut the donor tissue in such a way that a vertical uniform force is applied, like shown here. So care should be taken so that the Teflon block does not slip. And after punching, what we can do is the scleral rim is grasped and spun gently to see if the graft has been punched adequately. That is, it has to be completely punched on all sides, because there is a chance sometimes that it gets incompletely punched. So the graft site is ideally kept 0.25 to 0.5 mm larger than the host because of the difference in the endothelial and epithelial side cut. There are many different types of trephines. Most commonly, handheld trephines are used. So coming to the host cornea trephination. So now we have prepared our donor cornea. So let's go on to the host cornea. So trephine is continuously rotated till we reach around 80% of depth, so as to prevent any inadvertent injury to the iris or the lens. This can be about 7 to 8 quarter turns, each quarter turn being around 70 microns. There should be a controlled anterior chamber entry, should be done under viscoelastic cover, so as to remove any synechiae if present, and so as also not to cause any trauma to the lens or the iris. The cut can be completed with beveled corneoscleral scissors, there can be a right-sided as well as a left-sided scissors. Make sure that the blades of the scissors must be visualized at all times so as not to damage the iris. And viscoelastic can be injected into the AC during this process so as to make the process less traumatic. And any tissue tag remaining can be trimmed. An ideal cut would be perpendicular and helps to reduce postoperative astigmatism. So finally, coming to I would say the final step in the surgery, which is suturing. So there are 4 types of suturing that can be done in a PK, which is interrupted, combined interrupted, as well as continuous, single continuous, and double continuous. Most commonly, we use interrupted sutures. So prior to suturing, the donor tissue is transferred from a dish to a bed of viscoelastic so as to reduce endothelial cell loss. So initially we start with 4 cardinal sutures. They are placed at 12, 6, 3 and 9 o'clock, forming a diamond-shaped configuration as shown in the diagram over there, which tells us that the sutures are equidistant from each other. The 10-0 nylon sutures can be tied in a 3-1-1 or a 2-1-1 fashion, and the knots are cut flush with the tissue. Once the cardinal sutures are completed, the surgeon proceeds to use any one of the suturing techniques that mentioned earlier. So with interrupted sutures, ideally we want 16 sutures as shown here to close the wound. Interrupted sutures ideally are used in children, in infants, in highly vascularized corneas, especially in therapeutic keratoplasties. The main advantage of interrupted sutures is that it allows quick replacement if necessary and selective suture removal. The sutures must be kept at a depth of 90% on both the donor as well as the host, and around 1 mm on either side of the tissue. So full thickness sutures are not preferred because they can form a tract for microorganisms spread into the AC. So this following diagram here, it depicts when the suture bite is too shallow. If the bite is too shallow on the donor side, it leads to undermining of the graft. If it is too shallow on the host side, it can lead to graft overriding. If both the donor and the host have shallow bites, it can lead to leaving the posterior wound edge open. So we want it to be exactly 85 to 90% so that a watertight closure is ensured. So how do we know if a suture is too tight or too loose? So in case of a very tight suture, we will be able to see radiating folds as shown here in the photo at the area of the suture that is applied. In case of a loose suture, the wound can appear ectatic and you can see the loosening, obvious loosening of the suture that is seen here. And when it comes to burying the suture, it is burying on the host side reduces risk of wound dehiscence at the time of suture removal, whereas burying at the donor side increases the distance between the knot and the limbal vessels, reducing inflammation and potentially the chance of rejection. Unburied knots are a no because they cause foreign body sensation and also act as a nidus for infection. So continuous sutures, there can be three types, that is your torque, anti-torque, and no torque. Anti-torque is when it reduces the torsional effects that can be associated with radial bites. With anti-torque sutures, the graft is rotated clockwise. And with torque, this rotates the graft counterclockwise. And in no torque sutures, an isosceles triangle is formed, and so there is no rotational effect like in torque and anti-torque sutures. So post-operatively, patients are started on a tapering dose of topical steroids, antibiotics, and any other supportive medication if required. Sorry, hello? If required. So what do we look for on the first post-operative day? Look at the clarity of the graft, whether it is clear or edematous. Look at how many sutures are there. Are there 16 sutures, or have you taken more sutures? Look at those. If they are buried properly, and if no suture knot is exposed, look at the integrity of the graft host junction. See if the AC is formed, if the pupil is round. Also stain the surface to see for the presence of any epithelial defect or if there is any leak from the graft host junction. And finally, check a digital pressure for intraocular pressure. So, of course, there are a myriad of complications which can happen, both intraoperative as well as post-operative complications, which I'm not going to get into. So advantages of PK is it eliminates interface issues, allows anterior segment reconstruction in a single procedure, and it can treat full thickness diseases. Disadvantages, it is, of course, it causes irregular and high astigmatism and refractive error. There is a difficulty in controlling anterior corneal curvature. Neurotrophic disease can lead to non-healing epithelium in a lot of cases, and the wound is not as stable as it would be in a lamellar procedure. So graft rejection, what is graft rejection? It can be of three types, which is epithelial, stromal, and endothelial, which is the most common. Signs we look for, ideally learn what is Codadose line, which we'll also be talking about now. But the most important sign that you look for is the patient will come with a history of acute diminution of vision, redness or congestion, irritation. You'll see a diffuse edema on the graft with probably some KPs or endothelial pigments. And sometimes if you're able to see into the anterior chamber, some anterior chamber reaction. Treatment, you start the patient on, you give an IV methylprednisolone course, 500 milligram IV, followed by a course of systemic steroids and topical steroids, increase the topical steroids. Also make sure that the sugars in the patient are normal in these cases. So in PK, patient selection is one of the most important parts of pre-op evaluation. High IOP must be controlled before planning for surgery. Sizing of the graft must be adequate. Host trephination should be done with minimal to no trauma, and sutures must be 90% of the depth and acceptably taut. So few viva questions which are a little bit important. Why is the donor button oversized in PK? So it's to prevent angle crowding, reduce postoperative glaucoma risk, and improve wound apposition. One case where the donor button can be the same size as the host is keratoconus. So what is difference between primary graft failure and rejection? Primary graft failure occurs immediately postoperatively due to a non-functioning endothelium, whereas a rejection is an immune-mediated response and has some inflammatory signs. So what is the most dangerous type of rejection? The most common, most dangerous is your endothelial rejection because the endothelial cells do not regenerate. So indications for DALC instead of PK, any anterior stromal pathology, for example, your corneal dystrophies, which include your stroma, macular dystrophy, granular dystrophy, even keratoconus. What causes post-PK astigmatism? Unequal suture tension, graft host size disparity, wound healing irregularities, very tight sutures, all that can lead to post-PK astigmatism. Management of endothelial rejection, which we just spoke about. What is corridose line? It's a linear arrangement of endothelial precipitates composed of inflammatory cells, which originate at the vascularized end of the peripheral donor cornea. And it usually starts at the periphery and moves towards the center of the cornea. And finally, what are the risk factors for rejection? So there can be host factors and technical factors. Technical factors, we just did talk about larger grafts, eccentric graft, therapeutic keratoplasty, any suture removal, loose sutures causing vascularization. Whereas host factors such as deep stromal vascularization, more than two quadrants, any ocular surface inflammation, herpetic keratitis are other causes. So this is just a table which differentiates between the different types of keratoplasty, which if you'll be getting the PDF, so you guys can read through it. Thank you.
Thank you so much, Dr. Madhuvanti. It was really nicely covered, and all the pointers that you discussed at the end would be very useful for all the postgraduate students. Any specific pointers you would like to tell these audiences, that if you have a short case or a long case, what should you be discussing, and how you should present the case of a graft?
So for PK, we presented, I think, exactly how we went through the history. You ask about any previous previous ocular infection, previous any ocular surface inflammation. Why? What was the indication for PK? I think that is important. That has to be covered. So that slide on slit lamp examination and history, I think if they just follow that, that would cover the presenting illness as well as the past history. And even the so investigations would be what you do ASOCT, and again slit lamp examination, whether it's an opacity, the degree of opacity, extent of opacity, because all that decides on what kind of management that you're going to go ahead with. So yeah, I think that should be more than enough.
Thank you so much, Dr. Madhuvanti. Now
Thank
moving
you.
on to the next speaker, who is Dr. Divya. Dr. Divya will be discussing about iBanking and various media that are used in iBanking. Dr. Divya, are you ready?
Yes, I am. Yeah, I'll just share my slides.
Yeah.
Can you see my presentation?
Not yet. Dr. Madhuvanti, are you there?
Yes, ma'am, I'm here.
Yeah, so till the time Dr. Divya is arranging her slides, one more thing I would like you to talk about is how should one be looking at the tissue, just for the beginner surgeons. What should you be looking at while deciding the donor tissue details, as the forms are available?
I think Dr. Divya is going to be covering that anyway.
Yeah.
Yeah, so yeah, I think she's this one, but
Yeah.
Can
yeah,
you see my,
I
sorry.
think let her go ahead. Yeah.
Yeah. Okay.
Can you see my presentation now?
Yes.
Yeah,
I'm so
Dr.
sorry.
Okay.
Yeah. So today I'll be just taking you through iBanking and the various preservation media. So basic overview of today's class would be how defining iBanking and its objectives, which will include the basic setup of an iBank, the requirements of an iBank, etc. Donor screening, contraindications, donor preservation medias, the various medias used today, and a bit about the donor cornea evaluation also. So when you look into the when you look into the history of iBanking and transplantation, just for us to know this. The first corneal transplant was performed by Dr. Edward Zerm in 1905, and Dr. Townley Peyton is the father of modern eye banking. And in India, the first eye bank was established in 1945 in RIO Chennai by Dr. E.S. Muthaiya. And from then, the eye bank system and eye banking has, taken many leaps in the, following decades. So what to expect from the exam point of view? I think it's mainly in theory. The questions that are mainly asked is mainly on the preservation media and the constituents of the medias, and a little bit about, they even ask about the eye bank concepts, the requirements, the setting up of an eye bank, etc. So I'll try to cover most of these topics in today's class. So iBank is an institution responsible for harvesting and processing donor corneas and distributing them to trained surgeons. The iBank Association of India is a national non-profit organization serving as the apex body for eye donation across India. It promotes eye donation, standardizes the eye banking practices, and coordinates efforts to prevent corneal blindness. In India, eye banks are registered and should be registered under the Transplantation of Human Organs and Tissue Act. So when you talk about an eye bank, which comes above an eye bank, it comes the eye bank system and the whole infrastructure of the eye bank system. So this is basically a 3-tier system. So you basically have eye banks and you have corneal retrieval centers. So in the bottom of the pyramid, you have eye donation and retrieval centers. So these centers, basically their role is public and professional awareness. They harvest corneal tissues and they also transport these tissues to the nearest eye bank or the eye bank that they are affiliated with. The eye banks, which form the middle of the pyramid, they harvest corneal tissue, they process, preserve, and evaluate these tissues, store them, and distribute these tissues for transplant to surgeons. And the eye bank training centers are also eye banks, but additionally to the eye bank functions, they also train all level of personnel of an eye bank. So this is basically the general eye banking system that is followed. So when you talk about an eye bank as such, the basic structure, the eye bank operational team, it should consist of a medical director, an eye bank manager, an eye bank technician, and eye donation counselors or grief counselors. So these eye bank technicians are usually the ones who retrieve the corneal tissues in most of the eye banks. But these days, in many eye banks, they are even trained to evaluate the corneas and grade them for use and to share it with the surgeons who they are transporting it to. Next is an eye bank requirement. That is, to set up an eye bank or the eye bank to get registered, what are the requirements in an eye bank? So as you all know, it's the tissues are stored in refrigerators. They have to be stored in 4 degrees Celsius. So these the temperatures have to be regularly monitored in these refrigerators. There should be a laminar airflow hood. That is basically a no particle environment in the air system to provide proper protection to the tissues. Then a slit lamp, a specular microscope. Specular microscope is basically to read your to understand the health of your epithelium and get you the corneal count, the endothelial count. In recovery instruments, access to accredited testing lab, and also a standard operating manual. That is, every eye bank should have its SOP, that is its procedure manual, which is a must for every eye bank. Also, what are the types of donation? So voluntary donation or pledge donation is where the person goes ahead and pledges to donate the eyes. But as you all know, eyes are donated after, death. So the next of kin or the relative is the one also, have to give consent for retrieving the cornea in the deceased person. So hospital corneal retrieval program forms a backbone of the eye bank system, these days. So in this, the eye banks are directly affiliated with secondary or tertiary level hospitals, and they are noted by the grief counselor or the hospital when there is a death in the hospital, and the parents, the next of kin are counseled and motivated for eye donation. And what are the various retrieval techniques? So you have whole globe enucleation and the corneoscleral rim excision. So corneoscleral rim excision is what is more commonly done today. And as Madhvanti had explained in the previous talk, pre-cut tissues are also becoming more popular these days in many eye banks. For such eye banks which do provide pre-cut tissues, in the eye bank infrastructure itself, they need an operating microscope and the facilities where they can cut the tissue and prepare them before they are transported. So next is the donor history evaluation. So now that is, we've already spoken of the basic structure of an eye bank. So when you go to retrieve the cornea for, when you go to retrieve the cornea, you have to look at the age, medical history, the consent form has to be signed, the eye has to be examined just locally to, rule out any local signs of infection, etc. So why is that important? Because you have to understand that there are many contraindications for, using a donor corneal tissue. So any kind of systemic infections, basically septic patients who die of septic shock, any syphilis, HIV, hepatitis, any progressive neurological ailments, any systemic malignancies like leukemia, lymphoma, etc. Ocular conditions like any infections, endophthalmitis, viral infections, etc. Ocular malignancies, these are all contraindications for using the donor cornea. So the proper history is very important. Also, once the tissue is recovered, serological tests are also done of the donor, and finally the cornea is placed in the preservation media. So when you talk about the preservation media, you have a short-term, intermediate storage, and long-term. So basically broadly classified into these three categories. So in the short term, they can be stored up to 4 days in the temperature of 4 degrees Celsius. And the commonly short term are moist chamber and MK medium. Moist chamber is not really used these days. It was a very old method of corneal preservation. Intermediate storage up to 14 days is Optisol, Cortisol, etc., which are more commonly used intermediate medias these days. And long term are organ culture, glycerol, and cryopreservation. So when you talk about the preservation media, I think in your theory point of view, you have to kind of just kind of understand these classifications which comes into these, and also you have to, I think, know what the contents are roughly. So you just have to probably just learn it up. So the basic MK medium is most commonly used short-term media. So that consists of a tissue culture medium, antibiotic to prevent any contamination, 5% dextran as the osmotic agent, HEPS as the buffer, and phenol red as the pH indicator. So every medium has a culture medium. It has an antibiotic, osmotic agent, buffer, pH indicator. So these are a must for every preservative, the media. When you talk about Optisol and Cortisol media, additionally 2.5% chondroitin sulfate is also acting as a osmotic agent and a membrane stabilizer. And it also has various nutrients, vitamins, ATP precursors, etc. So Optisol and Cortisol are the most commonly used intermediate media these days, and Cortisol here in India, it's more available and more affordable. So the long-term medias are not very commonly used, especially organ culture is, I think, mainly used in some European countries. It's really not used much here in India. Glycerol, yes, is used in many eye banks where the tissues are stored for a very long duration, 1 to 5 years. I think during COVID, we were using a lot of glycerol preserved tissues. So you can use in glycerol tissue more than 1 to 5 years, but the tissue becomes very edematous when you place it in the glycerol medium. And cryopreservation is again another long-term media where the tissue is stored at minus 140 degrees and can be stored up to a year. So this is briefly about the preservation media. So this is just an image showing the first one is the moist chamber, then you have the MK medium, the cortisol, and the glycerol. So the it's usually pink, most of these mediums. So when the color changes, it is a sign of change in pH and contamination, etc. So next is once you receive the corneal tissue into the eye bank, it has to be examined. A slit lamp examination is a must. You have to examine it for any scars, any kind of any infection, any haziness, anything, it has to be clearly examined in the slit lamp. And also a specular microscopy is done. This is a specular microscopy, especially in eye banks for analyzing the corneal tissues. So this microscope is equipped with integrated camera, analysis software, and an optical pachymetry device. And this is how it is placed. So the tissue is placed in this vessel here, and the image is seen on the screen. So you're able to see the endothelial cells, count the number of cells, and also see the morphology of the cells is also important to understand the endothelial count. So this is how you do a quantitative and qualitative assessment of the tissues in the eye bank. And finally, depending on the examination on the slit lamp and also the count, the donor cornea is graded as from excellent grade to a very poor graded tissue. So anything above 2500 cell count is considered as a good grade, as long as everything else is okay, that the epithelium is okay, the stroma is okay, etc. And the poor tissue is anything less than 2000, 1500 is a poor graded tissue. So poor graded tissue can be used for therapeutic purposes, or any kind of emergencies like tectonic transplants and etc. So finally, to come to the eye bank functions, all these functions, all these things that we talk about is a function of an eye bank. So the donor corneal retrieval, the tissue preservation, the evaluation, storage, and distribution kind of comes into the functions of an eye bank. Yeah, so thank you.
Thank you so much, Dr. Divya. That was really nicely presented,
Thank
and
you.
it will help the postgraduates a lot. So, in interest of time, I will move on to the next talk. From cornea to cataract, Dr. Ankit will be presenting on small incision cataract surgery. Dr. Ankit, are you ready?
Yes, ma'am. Can you?
Yeah,
Are my slides visible?
yeah, but you have to start from the beginning slide and make it full screen.
Is it visible now?
Yeah, but yeah, now it's fine.
Okay. Good. So good evening, everyone. The topic of my talk right now is manual small incision cataract surgery, better known as MSICS. So the focus for the topic depends upon, basically it is oriented viva oriented, because less likely it is that you're going to get a full question on on SICS. So, and mainly, people, by the virtue of the surgeries that you do, you actually know about the surgical steps and a lot of things. They're just a little points that we miss, and what the examiner is more interested in asking. So the focus mainly should be on pre-op preparation, anesthesia, steps and techniques, intra-op complications, post-op complications, and instruments. So coming to the history, Jack A. Singer, he was the person in 1991. He devised an incision that is known as frown incision. So it's a common question that is asked, that why is it known as a smile incision or a frown incision? So basically, it is the incision, it is the expression of the surgeon. So that is why it is frown. Like the way you make your mouth, shape your mouth, that is how you incise. Paul H. Ernest devised triplanar incision. Paul Koch had incisional funnel. The concept of incisional funnel, which says that how far are you going to incise, is your incision being made, and the effect of it on the astigmatism. So coming to the infection prophylaxis, the basically it is the sterilization of the ocular surface, neutralizing the organism that may have an effect during the the surgical period or the post-op period. Prophylaxis, as we know, preoperative, perioperative, and post-operative, most important, because everybody knows how the steps of the surgeries, because we have been doing it for the 3 years. So systemic factors, preoperative, diabetes mellitus, 140 mgdl, it should be less than that, and the postprandial should not be more, it should be less than 200. Then if it is something, if the patient is diabetic and the parameters are not fine, you should defer the defaulters. HbA1c should be seen within 1 week. If there is no loci of infection in the body, or cellulitis or boils or hematogenous spread, it can lead to a lot of problems. Local, the lacrimal drainage system should be seen. It should be patent by Roplas or syringing. Lids, meibomian gland dysfunction, and allergic dermatitis is something which should be always be checked. In herpes simplex, the virus infections, the cataract surgery should be done only after 3 months after complete resolution and under the systemic antivirals. Conjunctivitis, it should be treated properly with the CS swab. And pre-existing dry eyes, you should be very cautious about when and how to operate it. Coming to the anesthesia, peribulbar, retrobulbar, subtenons, and topical. Common questions are going to be that what injuries can you cause while giving a block? And one of the best thing is, the sterilization of the ocular surface, which is very important. And that is something which all the residents do. They start doing it even before surgeries. Preoperative topical antibiotics have to be put. Povidone iodine 5%. It should never be underestimated. That is a one important thing that should be done, always. Followed by sterile draping. Another question is, what is the source of infection? Mostly it is ocular surface flora, if it's not taken care of. Then a few things are there which are not in your hands, like the OVDs and irrigating fluids and the surgical instruments. That's why it needs proper sterilization. Now, when you sit for the surgery, most common questions are, you hold the superior rectus, they'll give you a superior rectus forceps, and they'll ask you, but the intention is not for you to identify the instrument. It is that they'll ask you the level of insertion of it. So how it goes is 7.7 mm, like from the limbus, followed by lateral 6.9, then inferior 6.5, and medial 5.5 mm. So this is the question. The ideal size of external incision in a standard MSICS. It's always 5.5 to 7 mm. Allows easy nucleus delivery without phaco. So after that, you take a conjunctival flap, and it should be crisp and cut at the limbus. Adequate conjunctival cautery should be done, not more, not less. The tunnel incision that you're making should be in the blue zone, 2 mm away from the limbus. And that is how it is done. In MSICS, the external corneal incision is kept 1.5 mm larger than the external, because you have to respect the funnel shape for self-healing. The self-healing mechanism of MSICS tunnel is due to the very important concept, that is triplanar funnel shaped sclerocorneal tunnel. So in which the internal incision is, internal width is wider than the external one. So this is the triplanar entry that is done, 1, 2, and 3. That is how you enter it. Incision types. There are different sorts of incision types that are normally seen. So now people say that chevron has a minimum astigmatism which is impacted upon the cornea. Frown is very used commonly, and if the examiner is witty, they'll ask you that why the names are like this. As I told you, it is based on the expression of the surgeon. Preferred shape of external scleral groove in superior MSICS is frown, as it reduces against the rule astigmatism. Coming to the capsulotomy, these are the different 3 ways which is done: can opener, CCC, and envelope. That has to be like, these are the 3 main things. And then there is Sterling spark, which is done in hypermature cataracts. The golden ring sign, it is seen in, so many people they say that it is seen in hydro dissection, but then the correct answer is hydrodelineation. This is something like you should never miss. Coming to the hydro procedures, hydrodissection is something which we always know, but we don't know that what layers of between what layers do we push the fluid. That is a crime. You should always know it. Another important thing is that if the viva is going really fine, they'll ask you what is delamination. That is basically hydrodelineation. Coming to the nucleus prolapse, mechanical prolapse of the nucleus into the antral chamber, it can be done mechanically or bimanual technique. Bimanual technique is done. Most important step to prevent PCR in MICS is adequate hydrodissection. So hydrodissection has to be fine, and a large CCC. So this is something we just have to read it to check the boxes. How do you deliver the nucleus? Sandwich technique, in which you actually make a sandwich with a Sinskey hook or a visco cannula, and you just take it out. Modified fish hook, it is not used nowadays, but it was very prevalent before. So then if the examiner is from an older generation, they will always expect this answer. Irrigation for nucleus delivery, that's the most common, and it is done properly, or with the Vectis. So they'll always ask you that what is the problem that happens when you try to deliver it with the Vectis. Then you have to answer that when you deliver it with the Vectis, you have to make sure that you tend to push the iris of 6 o'clock. So then they'll ask you that how do you make sure that you don't cause any complications? So you see, whenever you put the visco, the Vectis, behind the nucleus, the tip of the Vectis should be visible to you. That is why it means there is no iris behind. That is how to do it. Another question is asked if things are going very fine, is that when you pull the nucleus, please tell me another name for Vectis. So that is Lewis loop. That is something that you should know. Another mode of delivery is nucleus bisection or trisection technique, in which we just go with a bisector and we bisect it. And the trisector technique, in which you go and we trisect it, as simple as that. Snare technique, in which a snare is made from a wire loop and then it is used to cut it. Modified Blumenthal technique with an ACM. in which you just go in with the AC maintainer on and you just pull it out, pull the nucleus out. Next question would be that in cases of stuck nucleus, how would you do? So you'll put the visco, if the nucleus stuck at the tunnel, you'll put the visco, push the nucleus to 6 o'clock and reattempt with the victus. Then they'll ask, what will you do if that nucleus is stuck on the half is out and half is at the brim of the incision? Then what are you going to do? You're going to wheel it out with a dialer. In adequate nucleus delivery, you have to make sure that it can be because of incomplete hydro procedure, small rhexis, mid-iris synechiae, soft nucleus, hard brown nucleus, or a small pupil. So the end goal should be that the nucleus should be delivered in its entirety and smoothly. And the counter pressure technique can also always helps using an AC maintainer. Complication: if there is a luxation, it is because of faulty hydrodissection, small pupil or small rhexis. It can be because of ZD, PC tear, or nucleus drop. So you have to take care of the factors that facilitates nucleus extraction, and you can use irrigating vectors. It really helps. Take a screenshot of this because this is if things are going fine, this will be asked. The zonulodialysis, and what will you do and at what level. Same with the PC tear. How would you go about it, and when to stop? Same with the PC management. Take a screenshot of all this. That's when would you put a IOL in bag, and when would you put an IOL in the sulcus, and when would iris claw and the SFIs they'll come into play. So this is a quick surgery for your perusal. Whenever you see always take at least reply that you are taking superior rectus under a fleshy superior rectus under the microscope. Take a nick. It should be crisp, and you have to take it, expose the part adequately. Cautery should be adequate. You don't have to make it, the pure. You don't have to make it devoid of any red thing that you are seeing in your field. You have to cautery just your level of just at the level of your incision, and other bleeding vessels. You have to be very gentle with the incision that you're making. And basically, you tend to, there's a verbal diarrhea when, you're asked about the questions and steps of the surgery. So, just take a deep breath and just answer judiciously. Think about it and then answer, because you might be doing a lot of things, but when you ask for it, there's always a verbal diarrhea. Why an air bubble is put? Because many people, they fear that it may stain the endothelium, the tryphin blue. That is why they put the air bubble. So these are the very simple things in which, they ask you just to know that how well you are grasping the subject and how mindful you are about your surgeries. I'm just fast forwarding it a little. Then comes envelope technique and CCC and can opener for capsulotomy. You have to study about the rearing and shearing forces that comes into play. Hydrodissection is very important. And as you see now, the nucleus has been delivered. So in this case, visco expression mode was used. And more problem, you might be asked, why, what in SICS when residents operate, what is the cause of, hazy cornea the next day? It is because when while delivery and, don't put visco between the nucleus and the endothelium. That is the most common reason. There's no coating of the endothelium that is there. inverted S shape, that is for sure. Another one important milestone is that you don't have to put a lot of visco inside. Visco should be just adequate so that your working space is maintained. They'll ask you the full name of Simcoe, two-way irrigation aspiration cannula. That is what you have to say. You tend to read all the the complications and everything, but more often than not, we get stuck in all these little petty things. So MICS is preferred over phacoemulsification in all except. These are some silly MCQs which are often asked. Soft cortical cataract in young patients. So post cataract surgery infection. So we have to take care of the corneal, limbal, and scleral incision that is there, and you have to see for hypopion and reaction in AC. Octet score, Oxford score that is there, that has to be taken care of, and you evaluate your cases. And if you don't, please start evaluating it right now. It is a very good thing, and you should log when you log your cases. You should put your Octet score in it. And if endophthalmitis, as we see, 90% of infections are due to mostly gram-positive organism, Coagulase negative streptococcus. So this is something which you cannot miss, the differentiating features between TARS and endophthalmitis. So, and it would actually be considered a crime. Mainly in it, the time course, less than 48 hours and 3 to 7 days. Please take a screenshot of this and keep it for your perusal. Thank you very much. Thanks a lot. Questions are welcome.
Thank you, Dr. Ankit. That was really nicely presented, and the surgical video was very meticulously done too. In the interest of time, I would like to move on to Dr. Rakhi, who will be talking about phaco-dynamics. Dr. Rakhi, are you ready with your slides?
Yeah. Good evening, everyone. First of all, thank you for giving me this opportunity. Let me share my screen. Is my screen visible?
Yes, it is.
So phaco-dynamics, as you all know, it's a very vast topic. It's difficult to cover it in 10 minutes. So I will just brush through the main topics that a postgraduate need to know, especially when it comes to as a long question. And also there are some key pointers which the examiners ask, especially in practicals. So I'll try to cover them all also. So what is phaco-dynamics? Phaco-dynamics is basically the study of components that determine the surgical safety and efficiency in a phacoemulsification cataract surgery. The three basic components include the fluidics, the vacuum, and the ultrasound energy. Fluidics include the inflow and outflow, which maintains the anterior chamber stability. The vacuum is the one that helps to halt and to remove the broken cataract fragments. And the ultrasound energy is the main component which helps to emulsify or break down the cataract. So all these three components helps to determine the surgical safety and efficiency. The primary instrument that is used to control the phaco during the cataract surgery is the phaco foot pedal. Based on the excursion of this foot pedal, we go to different position. At the position 1, it is the irrigation alone. When we depress the foot pedal a little bit more, we go to the position 2, in which along with irrigation, we start aspirating also. And when we depress the foot pedal to the maximum, we go to position 3, where there is delivery of the phaco power along with irrigation and aspiration. So parts of a phaco machine, it includes a console, which is like the brain of the phaco machine, which includes all the settings and all the important pumps and everything. And then there is a foot pedal, which we discussed, and the phaco probe, which will be discussed later. Coming to the mechanism of action. The ultrasound energy is produced because of the vibration of the piezoelectric crystals, which is there inside this phaco probe. These crystals in a specific frequency, which usually is around 27 to 60 kilohertz, which produces this ultrasound energy. This ultrasound energy help in breaking down the cataract fragments by three main mechanisms, which include the direct jackhammer-like effect, the microcavitation bubble effect, which usually happens from the side of the phaco probe, and then there is an acoustic effect. So you can see the phaco handpiece towards the right hand side. So here it is usually made up of titanium. It also has a silicone hub and a silicone sleeve. The central part of it, that is the distal opening, is usually for the aspiration port, and on both sides you have the irrigation port. So here you can see again the sides, in the sides on both sides 180-degree apart, you have the irrigation ports, and the central port is mainly for the aspiration. And here at the end, you can see the aspiration line. There is ultrasound power line and also the irrigation line. There are different types of phaco tips available, and with different angulation, which ranges from 0 degree to 45 degree. So when the angulation increases, the cutting power increases, but the holdability decreases. Basic fluidics in a phaco machine. You need to know there is two systems that is acting side by side, which is the inflow and the outflow. Inflow is the irrigation and outflow is the aspiration, which needs to be maintained in a balance so as to maintain the anterior chamber stability. This is based on the bottle height or the pressurized infusion, the vacuum that we are going to set, the flow rate that we are setting, and the resistance, which is usually given by the cataract fragments. So in the position 1, which is the irrigation, when we are just in the position 1, what happens is that from the fluid bottle, water start coming from the irrigation line, and through the phaco probe, it goes into the anterior chamber and it helps to maintain the anterior chamber stability. This is what happens in the position 1. So this irrigation system basically helps us to cool down the ultrasound tip. This will minimize the heat generation, prevent the tissue damage. Also, it helps to maintain the anterior chamber stability. There is a principle for the bottle height. A 1 centimeter of height is approximately equal to 0.7 millimeters of mercury of intraocular pressure. Ideal height is considered to be 3 feet, which is 90 centimeter. So in all gravity-based infusion systems, when you increase the bottle height, the IOP also increases, which lead to deepening of the anterior chamber. But in certain cases, like in case of glaucoma, you don't need that much high IOP. So you need to lower down the bottle height. The new phaco machines have got the active fluidic system, which is a target IOP based infusion system, which provides a more precise control. Coming to the aspiration system, there are two types, which is the peristaltic pump and the Venturi pump. In the peristaltic pump, there is a set of rollers which keeps on rotating, and these rollers will start pinching on the phaco tubing. You can see here, this is a phaco tubing. When these rollers roll, they pinch the phaco tubings, which leads to milking of the fluid, creating a negative pressure that sucks in the fluid from the anterior chamber and helps in the aspiration. Whereas in a Venturi pump, it is based upon a pressure gradient which is based on the flow of a compressed gas. So let's learn about them in detail. This is an important question that is usually asked, with the different pump systems and what are the difference between a peristaltic and a Venturi pump. So in a peristaltic pump, as I told, there is a phaco aspiration tubing which is rotating inside a rollers, and this rollers start pinching the tubing, which calls milking of the fluid, which finally drains into the fluid drainage bag. In this case, there is a slow buildup of vacuum, however, and there is a large safety margin. So it is good for beginners, but the surge is more and the nucleus has to be mechanically approached. Second one is the Venturi type, where there is a flow of a compressed air, which is usually nitrogen, from a high pressure, low velocity system to a low pressure, high velocity system. And because of this flow of this compressed gas, this leads to a negative pressure gradient, which creates a vacuum, which is attached to a rigid drainage cassette, which helps in the aspirating or sucking up the fluid and collecting it as a waste fluid. So here there is a linear or a rapid buildup of vacuum even without the occlusion. So there is good followability. Nuclear and cortical matters get easily attached to the tip. Surge is less. Rise time is faster. Therefore, the safety margin in this type of system is lesser. So it is good only for experienced surgeons. So now let's recapitulate what happens in foot position 2 or in aspiration. Just like before, the fluid comes through the irrigation line through the phacoprop into the anterior chamber, and from the anterior chamber, the broken cataract fragments along with the fluid is being sucked in through the aspiration port. From the prop through the aspiration line, it goes into the machine. Through the pinch of rollers, it is being sucked out and thus collected as a waste fluid. Now, the important thing is the phaco power. This is another question. What are the factors that determines the phaco power? So, it is the ability of the phaco handpiece to cut the cataract, which is directly proportional to the stroke length, the frequency, and the efficiency of the handpiece. Stroke length is nothing but the distance by which the titanium phacotips moves to and fro. This is a most important factor. Normally, it is around 2 to 6 mils. Second factor is frequency, which is the number of times the tip moves. It is fixed for a particular machine, usually given in kilohertz. So there are different modes of delivery of this power, which includes a continuous mode, a pulse mode, and a burst mode. In a continuous mode, there is a constant phaco power which is given continuously. There is always on-off power. There is no off segment of power. Whereas in a pulse mode, the frequency of the power is constant, but the amount of power which is delivered per pulse depends upon the foot pedal depression by the surgeon. So, here the time is fixed, but the power is variable. Burst mode, burst of full power is delivered, but the frequency will depend upon the foot pedal. So the time is variable, but the power is fixed. Modern system has torsional mode also, which reduces the repulsion and better cutting efficiency. For example, the OSIL technology. So let me recapitulate again. In the continuous mode, the power is always on, and and the excursion, based on the excursion, the power increases. In the phaco pulse mode, the frequency is same, but based on the foot pedal excursion, the power given will increase. In phaco burst mode, the power given during each burst is same, but the frequency can be increased based on the foot pedal excursion. Now let's learn about the type of tip movements. There are two types of tip movements. Longitudinal means the forward and backward motion, but that can also lead to more repulsion. And the torsional one has a side-to-side oscillation also, therefore less chatter and a better efficiency. Few key terms which the postgraduates need to know, which can be asked in the practicals, include the holdability, which is the ability to hold the nuclear fragments. Followability is the ability of fragments to move towards the tip. Occlusion is the tip blocked by a nuclear material. And post-occlusion surge is a sudden AC collapse when the occlusion breaks. So we need to learn about surge a little more because that is usually asked in questions. So what is surge? So you just try to memorize this picture. So when we are occluding a nuclear piece, which you can see here, during occlusion, the vacuum rises. When the occlusion breaks, what happens? There is a rapid fluid inflow from the anterior chamber into the aspiration port. So this sudden movement of all the fluid into the aspiration port leads to a sudden chamber shallowing, which leads to a forward movement of the posterior capsule. So it can touch the phacoprop and can lead to a posterior capsular rupture. So how to prevent this? For this, we can use a lower vacuum. We can use an active fluidics mechanism. We can use anti-surge tubings or small bore tubings. Another question that is asked is, how are corneal burns or thermal injury caused during a phacoemulsification? The causes are usually when you use high power, tight incision, or when there is a sleeve blockage. So this usually leads to a corneal burn or a wound burn and a corneal edema. So to prevent it, we need to have adequate irrigation, better to use pulse mode, and better to use torsional energy. Finally, we are just going to revise. As you can see, from the irrigating bottle, there is a fluid coming through the irrigation line. It is going through the irrigation port into the phacoprop. In the phacoprop, the fluid finally goes and fills in the anterior chamber. The center part of the phacoprop, the phaco power is also given, which leads to breakage of the nuclear pieces. This, along with the fluid, comes through the aspiration line and it comes to the phaco machine's main part, that is the pump, whichever pump is there. And from there, by either by pinch mechanism or by Venturi mechanism, the fluid is finally aspirated from the anterior chamber and it is drained along with the broken cataract fragments. Hope you understood the basic mechanisms. Thank you.
Thank you so much, Dr. Rakhi, and the pictures that you presented were very beautiful. Thank you so much. Now, moving on to Dr. Pranita, she'll be talking about nucleotomy techniques. Dr. Pranita, ma'am.
Hi, Gunjan. I'll be just sharing my screen.
Sure, ma'am.
Just a minute. Is my screen visible to you?
Yeah.
I'll just make it full screen. Yeah.
Yes.
Yeah, so I think Dr. Rakhi has very well covered all the basics of phaco-dynamics, and I'll be quickly moving on to the nucleotomy techniques and phaco-emulsification. So the anatomy, we all know about the anterior capsule, the cortex, and the nucleus, and the posterior capsule has a greater curvature compared to the anterior capsule is something that you need to remember. That is important when you're making the trench. So understanding this anatomy about the groove and the curvature of the lens is also very important. So before you move on to the nucleotomy technique, you need to be also aware about all the instruments and equipments. So there are different type of phaco tips that you need to be aware of. The tips can be either a standard tip, as you can see, it can be a straight tip, as you can see in the top image, or you can have a Kelman tip, which is showing a downward angulation, which is important for usage in a hard cataract. And then you have a balance tip, which has a double angulation up and then a down. Again, it is useful for managing hard cataracts. You can also have a microflow tip or a cobra tip. And then understanding the bevel mechanism is also important. The tip can have a 0-degree bevel or a 15-degree, 30, 45, or a 60-degree bevel. So greater your angulation of your bevel, higher is your vacuum and aspiration that can develop, but the phaco energy that gets, a lot of phaco energy does get wasted. So while your 60-degree will give you a very good occlusion, but a 30-degree gives an optimal balance between the optimal utilization of the phaco energy as well as the vacuum aspiration that is generated in the anterior chamber. Different choppers are the sharp, blunt, and hybrid. The sharp choppers are used for central chopping in hard cataract, and a blunt chopper is usually useful in soft cataract and when you're doing a peripheral or a horizontal chop. And a hybrid chopper is good for both the condition, for both hard and soft cataracts. Moving on to the nucleotomy techniques, you can have either a divide and conquer or a phaco chop. We'll look into all these chopping techniques one after the other. So most commonly used techniques are trench, divide and conquer for beginners, and stop and chop once you have mastered the art of phaco. And then primary chop is something that you go on to once you have mastered the art of phaco emulsification. So first technique would be divide and conquer is what I'm going to discuss. So in this, you initially make a trench, and after that you rotate the nucleus by 180-degree to complete the primary trench, and then you widen the trench so that at least two tip width is what is achieved in the trench width, and then you rotate by 90-degree, create a second trench, and then with the help of two instruments, one being the phaco tip and the other being your Sinskey tip, which is used to then divide these trench into 4 equal quadrants, and following which you can then eat up these nuclei. So this is a video showing the divide and conquer technique. As you can see, first the epinuclear plate is being eaten up, and after the epinuclear plate is eaten up, you can see that the primary trench is being created here, and this trench is being then deepened. And once trench is created, rotation by 180-degree to complete the trench on the opposite side as well. And once at least 60 to 80% depth of this trench is achieved, then you rotate by 90-degree and create the second trench so that a cross sign is achieved. And after this cross is achieved with the help of two instruments, we divide these nuclei into four quadrants by manually dividing them and pulling them 180-degree apart. And this is how you achieve a crack. And if you have created an initial good trench, you can easily divide them into 4 equal nuclei, following which you can easily eat these pieces up. So that is how a divide and conquer works. Now, how should the foot pedal position and the phaco tip position be is something that you need to understand. When you're making a trench, when you first go close to the nucleus, the foot pedal position is at 0 and 1. Then you need to shave the nuclei, which is with the help of phaco foot pedal position 3. That is, you're giving phaco energy to eat up the nucleus as you move forward. And once you retract back the tip to take the second shaving of the nucleus, at the time of retraction, it is important that your phaco foot pedal is at the position 0 or 1. And then when you shave the nucleus again, go to foot pedal 3. So this change from 3 to 0 and back to 3 ensures that you're not wasting your phaco energy into the anterior chamber, and unnecessary phaco energy leading to unnecessary edema of the cornea is something you can avoid by transiting your phaco foot pedal from 3 to 0 when retracting the tip. Now, when the phaco settings is very important to understand when you're doing a divide and conquer, creating a trench. You don't need a good holding of the nucleus. All you need to do is eat the nucleus away. So you use low vacuum and low aspiration because you don't really want to hold the nucleus. You just want to eat the nucleus. So torsional power based on the grade of the nucleus, you decide. So a high phaco power and low vacuum and low aspiration is something which is good for creating a trench. Now, what is a good trench? The trench should extend, the length should be up to the capsulorhexis. Do not try and go up beyond the capsulorhexis because in that ways you can damage your rhexis margin. The depth should be at least 1 tip deep and the width should be at least 2 tip wide. And once you start seeing the fundal glow, that indicates that you have an adequate depth. So don't go deeper than that. Once the glow starts coming in, that means the depth is adequate, and then you need to go for the crack. The instrument should be deep enough in the groove, and only if the instruments are deep, you'll be able to achieve a good crack and give adequate traction 180-degree apart. Don't press the nucleus down. It is only sideways movement that you need to give to crack the nucleus. If your two superficial instruments are either superficial and the movement is not proper, you will not be able to achieve a good crack. The next technique that we'll be talking about is the direct chop. In direct chop, rather than creating a trench, what you're trying to do is hold the nucleus, impel the nucleus, and hold the nucleus right in the center, and then divide the nucleus into smaller pieces. So you're not creating a trench and you're not manually dividing it, but you are holding the nucleus with your phaco probe and then creating the divide with the help of a chopper. So looking at this, again, it is important that here holding of the nucleus is very important to achieve a good crack of the nucleus. So once you go close to the nucleus, you nudge the nucleus as phaco foot pedal position 2, then bury the tip with phaco foot pedal position 3. And once your tip is impelled into the nucleus, then you transit back to phaco foot pedal position 2 so that you're able to hold on the nucleus with the vacuum and aspiration that has been built up in the tip. And then with the sideways movement of your the side instrument, which is a chopper, you're able to achieve a crack. So in this, you need a high vacuum, high aspiration so that the holding of the nucleus is good, because that is what is going to allow the slippage of your nucleus from the phaco probe and allow a good division or a cracking of the nucleus. The phaco power here depends upon the grade of the cataract. I usually prefer to start with the low power and increase the power depending upon the requirement. So start from 20-30 torsional power, and you increase if you are not being able to emulsify the nucleus or not being able to impel the nucleus. If you start from a 50-60 power and if your tip eats away the nucleus, then you are not able to hold it again because the central part tends to become a crater. So start from a lower power and increase it as per the requirement. The chopping can be either a horizontal chop or a vertical chop. So by horizontal chop, what do you mean? That you take the probe, you take your chopper in the periphery beneath your rhexis margin up to the equator of the nucleus, and then move the chopper and the phaco probe towards each other, and the nucleus between these two instruments breaks down. While in a vertical chop, you impel the chopper in the center in front of the phaco tip, at its left edge and border, and there is sideways movement that you are trying to achieve, and that way you divide the nucleus. We'll see a video that will better explain of the procedure that is happening. So this, you see, there's a blunt chopper that is being used. The chopper was taken right underneath the capsulorhexis margin and up till the extreme periphery, and it was brought towards the phaco tip, and you see the chopper and the tip were moving towards each other, and the nucleus in between got split into pieces. So that is a horizontal chop. You can use it for hard cataracts, while in vertical chop, as you can see in the video, the nucleus is being impelled in right in the center. You're using a sharp chopper which is placed at the left edge of the phaco tip, 2 millimeter in front and 2 millimeter to the left of the left edge of the tip, and sideways movement 180 degree apart, a 180 degree opposite direction movement of the tip and the phaco tip and the chopper allows easy cracking of the nucleus. So the movements are quite different in both the techniques. Now, inability to chop can be because of the superficial impalement. So when you're impaling the nucleus with the tip, your depth should be at least 50% depth. If you're too superficial, when you're trying to chop, the nucleus will just slip away. Second reason why the nucleus slips away is because of a low vacuum and aspiration setting, or staying in foot pedal position 3 for a very long time, which eats up the entire nuclear matter, and once you reach the periphery, which is too soft, you're not able to crack it again. Again, improper positioning of the chopper is also very important. In case if you're placing your chopper right in front of your phaco tip, when you do the sideways movement, the nucleus gets disengaged from your phaco tip. So try and be at the left edge of your phaco tip, and slightly on the in front and slightly onto the left edge of the phaco tip. And if the cataract is too soft, that can also be one of the reasons to be for the nucleus to slip and inability to chop. Stop and chop is the third commonly used technique, that is basically a combination of the divide and conquer and the phaco chop. In this, you create a central trench divided into two halves, and then you go on to the primary chopping technique that has been described. The trench and chop settings have to be, as we have discussed in the trench, you'll have a low vacuum aspiration, high phaco power. When you move on to the chopping, primary chopping, in that you'll have a high vacuum, high aspiration, and phaco power as per the grade of the cataract. So this is a video showing that you are creating a central trench, and after the trench is created, you divide the nucleus into two halves manually with the help of the Sinski and the phaco tip. As you're seeing here, a good crack is being achieved. And after the trench has been completed, then you move on to primary chop. Here you can see again a trench and a divide, and then you rotate the nucleus, and then you go on to you complete your division on the opposite direction as well, and then you move on to going on to the primary chop technique. So this is how a stop and chop technique works. Now, after you have broken up the pieces and broken up the nucleus into small pieces, then you need to aspirate it from the central safe zone. So don't try and emulsify the nucleus in the periphery. Removing the first piece is the most difficult thing. So whichever is the smallest piece, try and mobilize it completely, bring it to the center and eat it up. And the plane should be usually try and eat up the pieces at the pupillary plane. If you're very confident and experienced, you can do in the back phacoemulsification. Otherwise, an iris plane phacoemulsification is a good compromise. However, avoid doing a phacoemulsification in the anterior chamber because that leads to a lot of endothelial cell loss. So when you're going in the periphery, you need to nudge the nucleus, go to phacofoot pedal position 3, embed the tip, and then pull the nucleus to the central, come back to foot pedal position 2 so that you don't eat up the nucleus, bring it to the central safe zone, and then once it is in the central safe zone, eat it up by going on to phacofoot pedal position 3, and then move on to the next piece. So in this, a high vacuum, high aspiration is needed because you need a good hold of the nucleus, as well as the phaco power needs to be high because it depends. If you're managing a hard cataract, you'll need a high power. If it's a soft cataract, you can even get away with a low torsional power. So there are different ways to manage the nucleus and doing nucleotomy. However, to begin with, it's a good divide and conquer, or making a trench is a good technique to avoid complications, and then transit to your trench, and then transit to the phaco chop technique. So you need to initially practice the foot pedal transitions is something on which you need a very good control before you move on to the phaco chop. The transition between 3-2 and 2 and 3 needs to be perfect so that you have a good hold when you're trying to divide these nucleus, divide the nucleus. And also a good advice is that you always look at the machine settings before you start the case, because you don't know what the previous surgeon was operating upon, and begin with trench and then shift to phaco chop is all I would like to advise to the students. So with that, I would like to conclude. And I would like to thank Dr. Praful for, immaculately making such a beautiful program, and Dr. Gunjan for, moderating the session and making the program so smooth.
Thank you, Dr. Pranita. It was very nicely covered, and you talked about the nucleotomy techniques. I'm sure all the residents will be getting good teaching pointers today. So I'll be in interest of time, we'll have to move on to the next speaker, who is Dr. Arpit Sharma, who'll be talking about endophthalmitis. Dr. Arpit, are you there? Dr. Arpit?
Yeah, thanks for having me. I'm just sharing my screen now.
Yeah.
So I'll be briefly talking about endophthalmitis. It's although a vast topic, but we'll just try to shrink it in 10 minutes. So what is endophthalmitis? Second. It's nothing but the inflammation of the intraocular tissues like coats and the contents. But moment it goes to sclera and beyond, we call it a panophthalmitis. It's usually an infectious condition, but occasionally it can be non-infectious also. And usually it's a medical emergency. And it can be either exogenous or endogenous, with exogenous obviously being more common depending on the source, and endogenous usually comes after crossing the blood retinal barrier. And we can classify it by etiology as post-operative or a post-traumatic and others, and by timing being acute or a chronic one. And this timing was given by EVS, which said after 6 weeks it is a chronic one, and by organisms also. And why do we care about this classification? Because by the etiology, post-operative is the major chunk, causing 65% of all the endophthalmitis, followed by post-traumatic ones and the endogenous ones. Endogenous being a small chunk only, but very crucial chunk, because your diagnosis can be life changing. So what are the clues? Like, patient is coming to you with endophthalmitis, how do you know what kind of endophthalmitis you are dealing with? The first clue comes with the timing itself. If the patient has come after within 24 hours of the surgery, think of TAS, toxic anti-segment syndrome. And if anything more than that, be it days or a week, think of an organism. And as late the patient is presenting, think of the less virulent the organism is. And after 6 weeks, think of some organisms like a Propionibacterium acnes or a fungus, which can come even after 6 weeks. So what is TESS that I just mentioned? So TESS is the kind of inflammation which happens after cataract surgery. Within 1 day, patient will be having absolutely no pain or very little pain. And the basic clue is there will be limbus to limbus endothelial corneal edema, because there is a toxin left behind in the anterior chamber. There will be AC cells or a fibrin. There can be a hypopion also, but surprisingly, there will be no vitritis. And these patients respond very well to the steroids. And obviously, they are culture negative because it wasn't an infection to begin with. The other clue you will get is by the clinical assessment, because all these patients will be coming with vision loss or a pain or a redness. But what kind of a hypopion there is? What kind of a vitritis there is? These all things will give you more clues. And suppose you have a B scan. So this was one of my patients where although there was endophthalmitis clear cut, but on the B scan I found there are some subretinal abscesses also. And this patient didn't have any symptoms of a systemic infection and was nicely having a bacteremia. And we treated this patient with a linezolid with a good outcome, life-wise. And suppose there is a hypopion, even that can give you a lot of clues. Like a serratia will have a pink hypopion, or a fungus will have a gray or white hypopion. A tumor can have a brown or a black hypopion, especially with if there is a tumor lysis of a uveal tissue. And other things, like suppose you are seeing a vitreous like this and you are saying, okay, this is some string of pearl kind of an appearance. Yes, this kind of endophthalmitis can happen in infectious causes also, especially with the yeast, like a candida. But the same picture can happen with a lymphoma. Same picture can happen with a nocardia infection. So keep your differentials very clear. And even other things which can cause intermediate uveitis or pars planitis can sometimes have a vitritis which can appear like an endophthalmitis. So you need to have your differentials very clear. You have to see the entire picture. And the most important clue for you will come from the microbiology. So what to send for a microbiology? Send everything. If you have aqueous, vitreous sample, suture, foreign body, whatever you're finding, bag complex, send. But the most important sample for you is vitreous. So either as a vitreous tap or a vitreous biopsy. And many organisms can cause endophthalmitis. We'll be discussing only the clinically most important ones which can be asked in the exam. So now you know that it's endophthalmitis. You have used all the clues. Now what will you do? How will you manage? So it's an emergency. We don't delay the management. We have to go for the first straight away management. But how do we start? Like, do we tap and inject? Do we do a vitrectomy? How do we decide that? So this question was answered by EVS study, endophthalmitis vitrectomy study. So what they answered were two questions. A, if the patient is coming with endophthalmitis, whether doing a primary vitrectomy is better or doing a tap and inject is better. And secondly, if you are adding a systemic antibiotic, whether it will add any benefit to the already given intravitreal therapy. So they only included patients who were acute endophthalmitis. I said that 6-week figure was given by the EVS study. So this is how they used it. Any endophthalmitis less than 6-week duration from post cataract surgery also, but also secondary IOL. This is something that people tend to forget. This even secondary IOL were included in this study. And secondly, the vision was between 20/50 vision to PL positive. They didn't take a 6/6 vision or a 6/9 patient, 6/9 patient, only 20/50 to PL positive. And there has to be a adequate view for a vitrectomy. Iris detail should be visible. The media should be clear enough for doing a vitrectomy. And the patient should either be having a hypopyon or a vitritis, which is obscuring second order retinal arterioles, not even venules, arterioles. And they called it a grade 2 or anything worse than that. And they excluded patient with a chronic endophthalmitis or a non-cataract issue or anything which could have obscured the view, like I just said, or anything which could have caused a poor vision, like a retinal detachment at the baseline or any poor preoperative vision, or even a young patient or a monocular patient for the ethical reasons. And this is how they graded the media clarity. So if you don't remember the entire classification, just remember grade 2, second order retinal vessels, that is arterioles. And even with the vision measurement, they were very, very meticulous. So suppose patient is not able to read anything on the ETDRS chart, they went to the counting fingers and then they just noted that, okay, 6 meter or 3 meter or 4 meter. Suppose patient is not able to count till 1 meter also, then they switch to hand movement. So how the hand movement was checked? First of all, even suppose that there is a PL positive patient only able to see light. And if you are just waving your hand in front of his face and there is a light behind you, the light will come and go and the patient will seem, okay, yeah, I can see something which is moving, and then that will also become a hand movement. So to avoid that, the light source was placed behind the patient, and the person who was examining was standing in front of the patient 60 centimeter, and the patient has to get it right at least 4 out of 5 times. The 5 times patient will be checked. Anything less than 4 also, the patient will directly go to the PL light perception group. And the randomization was also two stage. One was either to do a immediate vitrectomy or tap and inject, and secondly, whether to give a systemic antibiotic or not to give a systemic antibiotic. And all these patients received intravitreal broad coverage antibiotics like vancomycin and amikacin. And for subconj, they received vanco and cefta. I mean, seriously, they didn't give cefta for intravitreal, they gave it for subconj and IV also. And they used fortified antibiotics like vanco and amikacin again. And all of them received topical and subconj steroids. What differed was the IV treatment, that was ceftazidime and amikacin. And both these antibiotics, brilliantly enough, were targeted for gram negative only. There was nothing given for gram positive IV medication. That you will understand from the results why this might have come negative. And this is why it is important to know the shortcomings of the EVS study also, not just knowing the study. So what they found out was, if the vision was better than PL, it didn't make any difference whether you are doing a tap in or inject or whether you are doing a vitrectomy. But if the vision was PL only, then vitrectomy was clearly better. 3 times better results of getting 20/40 vision and almost 50% reduction in severe vision loss, that is less than 5 by 200. At least these two numbers you should remember. And systemic antibiotics didn't make any difference in the final visual outcome. And these results you have to understand from the microbiological perspective also, as 30% of these patients had a culture negative. And even the ones which were culture positive, coagulase negative one was the most common one, that was amounting to 70%. And not surprisingly, culture negative ones and the coagulase negative ones had the best outcome. Rest all the bacteria had a bad outcome. So you know the results. Suppose this is a patient in front of you and this patient is also PL positive. Will you do a vitrectomy in this patient going by the EVS? No, because this patient is not even eligible for the inclusion criteria. You cannot even see the iris. So you need to understand those results well. You cannot use them anywhere. Even if this was a post-cataract patient, even if the patient was having hand movement close to face, obviously this patient will not have, but still, you cannot use the EVS guidelines for this patient. So what are the problems with the EVS? Like I just said, they excluded most of the severe presentations. That's where you need your intervention a lot. And secondly, remember that this was a very, very old study. This was a ECC era, not even a phaco era. And those days, there used to be a 20 gauge vitrector. There was no MIVS. There was no wide viewing systems. No fluidics where IOP is maintained. So this was a totally different era only. And this vitrectomy was only done for core vitreous. They didn't induce PVD. A lot of vitreous was left behind. And even the hand movement definition was very, very strict. Suppose patient is getting it right 3 times also, the patient will again end up with the PL positive vision only, even though patient might be having a hand movement close to face. 5 is too less for that. So the era that we are moving to right now is CV, that is complete and early vitrectomy for endophthalmitis. So what has changed? Now we have better fluidics. Now we have better viewing systems. So any fundus obscuring infection, you can directly go for a vitrectomy. The vision is not a gatekeeper anymore. You have to do a complete vitrectomy. PVD again is controversial. If there is a retinitis, don't induce a PVD. If the PVD is coming by its own, well and good. If you are seeing a macular hypopyon or if you are seeing any retinal debris, remove them. And idea is to remove the pus and the toxin as early as possible before it can cause any retinal damage. And compared to the EVS result, which was only 53% people getting 20 or 40 or better vision, now we are getting in almost 80%. So the things have changed. And this is how you should remember the EVS study also. So the your examiner may ask you, okay, now you know how to manage the endophthalmitis, but can you prevent it? Suppose you have done a cataract surgery, very good. You remember all your steps nicely, IOL is shining. Will you put an intracameral? So yes, there were studies answering that question only. One was by ASCRS. It was a randomized control study where they compared the cefuroxime with not giving any intracameral, and from 0.34% of endophthalmitis, it fell down to 0.07%. Huge fall. But think of it that way, that doesn't it look like that 0.34% of endophthalmitis is a baseline endophthalmitis rate is too high? Even Indian studies give 0.02% only. Maximum, even American studies will give 0.02, 0.04%. So this study again was problematic, although it did show a good results in Swedish cataract registry. Other medication that we are using these days for intracameral is moxifloxacin. And again, the problem is rising resistance. But what not to do? Don't use vancomycin straight away because of the HORV risk. And obviously, you are giving very high antibiotic for something. And if the resistance comes, you will not have anything to go back to. So let's look at some other cases also that can appear as an OSCE cases for you. Suppose a patient is coming to you with a chronic or a delayed postoperative endophthalmitis, more than 6 weeks, indolent infection. You're seeing a PC plaque. What will you do? You treat the patient with okay, there is some inflammation. You treat the patient with a steroid. Patient will initially have a very good response. And then the vitritis will come back. Because the bacteria is like that only. It has a very long incubation period and it forms a plaque. And the worst thing you can do is do a yak cap in this patient. And this endophthalmitis is very difficult to treat because it forms a biofilm. It entirely covers the bag. So you can give intra-bag injections and everything, but eventually you have to take out the IOL bag complex only. Another very fascinating situation is after corneal transplant. These patients, anything can cause endophthalmitis. Can be loose suture also, suture abscess also, graft ulceration also. Gram positives are common, but these days even fungal is becoming important after endothelial keratoplasties. But these patients will not have any pain. So you may miss the earlier window also in these patients. Then glaucoma surgery associated or blab associated or glaucoma drainage implant associated endophthalmitis are all bad. Very, very poor outcomes. And they can have endophthalmitis even years after getting a surgery. And classic appearance will be white blab over the red background. And yes, there is increased risk, especially if there is an inferior blab, or almost 7 times increase higher risk for the inferior blab, or if you're given a very high concentration of antifibrotics. And you will hear all these unusual organisms here, like a streptococcus. Post PPV endophthalmitis is again very interesting because there is no vitreous. So how will you know that there is a endophthalmitis? And after any VR surgery, there is some inflammation, right? So the only clue here might be there is a hypopion or there is an inflammation which is more than what you had expected from a case like that. Although it is rare, but then it can still happen. And you can reduce these rates by suturing your incisions. And the most common one these days, unfortunately, are becoming post-injection endophthalmitis. And you can prevent them if your patient, if anyone is asking how to prevent it, just say povidone iodine, because that is the only thing which has been proven. No antibiotic has been proven to um, reduce this rate of endophthalmitis. Again, cons is the most common endophthalmitis for any mechanism. But here, oral flora is also very interesting, and you'll know why exactly. Because a lot of time these post-injection endophthalmitis occur in clusters, especially when you're giving Avastin to your patients. So examiner can ask, you don't have to remember all these details, but at least remember few things. Like if you are giving an Avastin to your patient, check for the cold chain. Check whether the patient, the drug is counterfeit or not. Check the Klesler code or a QR code on that. Make sure you are opening that aliquot on the right environment, that is a class 100 laminar flow in the class 10,000 environment, or class 100 10,000 in short, if you want to call it. Use only a single puncture. Fill all the syringes in the single go only, and anything which is left behind, throw it. Don't store it. That is the main reason for cluster in most of the cases. And like I said, oral bacteria are causing endophthalmitis in these cases. So make sure absolutely no talking when you're doing all these things, be it filling the injection or even giving it to the patient, apart from just giving them the instructions of opening the eyes. So yes, so traumatic endophthalmitis is also a bit important, although not as common as some other endophthalmitis, but thankfully its rate is also decreasing. Now it is only 5% of all the open globe injuries have endophthalmitis, because we close the wound very early. And a lot of time we are giving prophylaxis also. But still it is much higher compared to the post cataract surgery endophthalmitis, the rate being 0.03 to 0.05%. And know this thing that apart from the duration, like how late you are done a open globe repair, other things which is the most important one, even not even the foreign body, is where did the injury happen and how dirty was the wound, because that will decide what kind of organism which has caused endophthalmitis. And what we dread the most is bacillus, especially bacillus cereus, which can kill the entire retina, almost entire retinitis in within 12 to 24 hours. And even fungal can cause, but that is a bit better course. Again, outcome is poor because you are not just dealing with the endophthalmitis, you are dealing with an open globe also. Often you are dealing with the lens touch also, or a cataract surgery also, or you are dealing with a retinal incarceration or an RD, or maybe even a suprachoroid. So overall, these eyes are bad. But the most important was endogenous endophthalmitis, because you have to remember this thing, because you can save lives with this. So any patient where you don't know the exact exogenous trigger for this thing, and patient has ended up with endophthalmitis, think of endogenous. Patient need not have a fever, need not have a UTI, burning micturition, nothing. You have to send all the samples and find out. Any risk factor you can think of endogenous endophthalmitis. And it can present like anything. It can present like a uveitis also. It can present like a small retinitis patch also, and then get worse. So suppose you have an endogenous endophthalmitis patient, just think of it two ways, whether it is a bacterial or a fungal one, because it makes a lot of difference how this endophthalmitis is going to act. If it is a bacterial one, bad course, acute, rapid onset, very severe. Patients, especially in West, can have endocarditis. In Asian, Klebsiella is very common, especially with the liver abscess. And Klebsiella can have a very, very bad prognosis also. But is a fungal, it is just like a slow burn. It's a subacute onset. There will be some chorioretinitis, some patch will appear, then the Brooks will rupture and the endophthalmitis will come into the vitreous. There can be string of pearl kind of appearance, which I had already mentioned with lymphoma also, or nocardia also. And they tend to have a good course comparatively, candida. But aspergillus, even though it is a fungal, doesn't have a good course. It is a very, very aggressive course. It can have a fungal abscess also. It can have a vasculitis also, or exudative retinal detachment also. And mainly, this aspergillus is happening in a very, very bad patients, like neutropenic patients or transplant patients, not just any indwelling catheter. So they tend to have a bad prognosis. So now I said many organisms can cause endophthalmitis, but we'll be only discussing the ones which can be asked to you in exams. So cons, obviously it will be asked to you in exams, like what is the most common organism in any endophthalmitis? That is coagulose negative staph, especially the species epidermidis, staph epidermidis. And staph aureus is bit more virulent than the staph epidermidis. Both of them can be vancomycin sensitive. Then streptococcus, think of blab related end of highly virulent, poor outcomes. Enterococcus, again, post-op or endogenous ones. Chunk of gram negatives are coming from enterococci. And the other surprise it can throw towards you is it can be vancomycin resistant also enterococci. Big chunk of gram negatives are coming from that. And you have to treat it with a linezolid,
Dr.
like
Arpit,
my
can you
patient I had shown initially.
Dr. Arpit, can you wrap up?
And yeah. So among the gram-positive ones, you have to remember I already mentioned Bacillus cereus or Clostridium. And for the Corynebacterium diphtheria, you have to just remember it is, although it is a low virulent organism, it is very persistent one, and you have to treat it with the vancomycin. And the Listeria, which is especially mentioned in the RAN, although it is very uncommon, there is a dark hypopion in these patients, and you have to treat them with the oral moxifloxacin or IV fosfomycin. And among the gram-negative cocci, again, not very common. You have Neisseria, which happens only with the complement deficiency patients, especially disseminated infection, and Moraxella, which is blab-associated. And Haemophilus influenza, think of blab-related only. And like I said, Enterobacteriaceae, which is gram-negative, huge chunk, think of ceftazidime in these patients, bad prognosis. Klebsiella, again, very common in Asians. That is an exam question for you. Think of diabetic patients and very bad ocular course. Pseudomonas, most dreaded one, happens in outbreaks and usually very highly drug resistant. You have to give anyways you are starting with ceftazidime only, and then apart from that you can think of amikacin or pepacillin, depending on how the culture comes. Remember that moxifloxacin will not work in Pseudomonas. So summarizing this thing, just remember most important organism for you is the cons. The organism virulence and the time to treatment will decide the final outcome. And if the initial vision is very good, think of EVS. It will have a good prognosis. Thank you.
Thank you so much, Dr. Arpit. Sorry for interrupting, but there's paucity of time. So we'll move on to the next speaker, which is Dr. Kedar. Dr. Kedar, are you there? Sir, can you please unmute?
Yeah.
Yeah, okay, sir. So you can start sharing your slides.
Is the slide is visible?
Yes, sir. Please make it
Okay.
full screen.
Yeah. At the outside, I want to thank the Dr. Praful and the organizing committee for this NPCB and for a very good PG program. Due to time constraint, just I will do it in a faster manner. See, NPCB, we should know about the history, objective and definition and types of blindness, and what is about Vision 2020. So the PG should know the types of definitions of blindness. Just you can get the, or you can get a photograph of these definitions. What is the low vision? Then the most important is vision less than 6/60 or visual field less than 20 degrees. These blindness are very important nowadays. Economic, social, manifest, absolute, curable, preventable, and avoidable. Just know the definitions for an exam point of view and also for a practical point of view. The most important is preventable blindness. So for the NPCB was introduced in the 1976. It was 100% central government program, 100% central government sponsored program. And then the main aim was to reduce the uh, blindness percentage, which was 1.3 in 2001. Now it is a 0.36, and we have to go towards 0.25 in 2025, 2026. In 94, that program was decentralized. And why? Because to involve the get involvement of the state level and the district level. So the main causes are cataract, glaucoma, then refractive errors, and corneal opacities. These are the main causes, and the main focus of this NPCB is to reduce these causes. The main objective is to identify and treatment. After identification, you have to develop the infrastructure at central level, state level, and district level. Then second is development of human resources, community awareness, research, and voluntary participation. At the central level, it is chaired by Secretary of Health, and there is a coordination committee by additional secretary. And there is National Technical Advisor Committee also by Director General. The main function of these people are procurement, then involvement of NGOs, then organizing central level training programs, information, education, communication, and procurement. The same is replicated at the state level also for the building of infrastructures, then manpower, and maintenance of these hospitals. Then it is reduced towards for the district level for the better implementation. For the better implementation and better monitoring, it is DBCS is also formed. The main aim is to optimal utilization of available resources. So what was the need? Because due to administrative or financial lacking or to approach, they have reduced towards DBCS. In PGs, you should know about what is Vision 2020. So it is a global initiative by WHO and IPB to reduce the blindness. In India, it was adopted in 2001. What are the objectives of Vision 2020? The reduction of disease burden, then HR development, infrastructure development. Now we have added it towards public awareness and information through different medias. Then also we have concentrated on the school health programs. Again, professional bodies like AIOS, IBank, IMA, Rotary, Lions, Lions Club. So the target diseases are cataract. Second is childhood blindness, because India is now becoming the global capital of myopia. So focusing on myopia also. Then corneal blindness, diabetic retinopathy, glaucoma. Then in childhood, vitamin A deficiency, injuries, or ophthalmic neonatal or any infections, or in few cases of ROPs also. The main aim is to avoid the causes of childhood blindness. So the primary immunization at the school level, the awareness and periodic checkup. For the prevention of childhood blindness, the xerophthalmia should be avoided. Then refractive error should be routinely checked up. if any requirement is there of medicines, then you can give the free medicines, free spectacles. Childhood glaucoma should be treated promptly and urgently, and ROP should be managed earliest. Then glaucoma is also one of the cause for the NPCB. For the prevention of glaucoma, the preventive like IOP measurement means visual field testings or ICAMs, and ICAMs for the compliance of the drugs, because many glaucoma patients or chronic glaucoma patients are not compliant to the medicines. So the ICAMs, that focus should be there. Then diabetic, everybody knows you have to do the indirect, then FFA, and after FFA, the laser therapies. Now, almost at the tertiary level and secondary level, uh, this program is initiated. Which are the strategies for glaucoma and diabetic retinopathy? See, at the district level also, now at the civil hospital, now they have introduced the slit lamp, then fundus photography, then visual field retinal evaluations, and in some states there is lasers are also available. What is the importance of intermediate? Means medical training, residency medical training, then CMEs in conference, hands-on training. Most important is public education, because many time people or patients doesn't know what this disease is. So all these factors will give you to high quality eye care and to reduce the burden on the blindness. Then in cornea, the corneal causes are corneal ulcers or a corneal injuries, keratomalacia. So for the corneal blindness or treatment, it should be early diagnosis and treatment. Then second is corneal grafting or eye bank formation. Then vitamin A deficiency should be treated urgently. For the mid-level training, now the ophthalmic nurses or ophthalmic technicians are increased. Many colleges are now increased in for the these nurses and technicians. Then optometrists, OT technicians. So this is a overall picture about the tertiary level, district and primary level, and it is all is interconnected. At the primary level, the screening is very important. The school eye screening is most important. Refraction and prescription and regular eye checkup. At the secondary level, we are all doing the cataract surgeries, but we have to go again for facilities for refraction and regular checkup, and we have to prevent the further manifestations of myopia or any referential services like for ROP or corneal blindness. And at the tertiary level, we have to do the we are doing the retinal surgeries, corneal transplantation, glaucoma surgeries. The most important part is training and CMEs and health awareness. Now it is no focus point on a tertiary level. At the center of excellence, we are all modulating all these formulas for the prevention of blindness. So just wrap up the activities of NPCBs. See, important is infrastructure, manpower, then prevention, school and teaching and health education. School eye screening program is very much important to reduce the burden. And again, when one child you have treated nicely, he will definitely treat or he will cure his family also. So that is very important. Or it will increase the awareness in his families. The new additions are provision of free classes, vitamin A, then myopia clinics, diabetic checkup, regular diabetic checkup. Nowadays, AR&D checkups also we are doing Okay, thank you.
Thank you so much, sir. That was presented very nicely. And for all the postgraduate students, NPCB is a very important question, especially for theory examinations. Thank you so much, sir. Would you like to add on to any tips for the PG students
Yeah,
here?
nowadays, NPCB is actually changed in 2017. Now NPCB has been renamed as a NPCB and visual impairment. NPCB visual impairment that is added. Second, the ratio. First, it was initiated by central government with 100% budget. Now, 60% budget is from central government and 40% for the from the state government. Again, I want to add about the Netra Jyoti Abhiyan that was started in 2022 to reduce the burden of cataract, especially for 26 lakhs, the target of 26 lakhs cataract surgeries within 3 years. Any questions?
Thank you so much. No, sir, not no questions in the audience yet. So, in the interest of time, we'll be moving on to the last speaker, who's Dr. Tushar. He'll be talking about artificial intelligence in ophthalmology, the burning topic in today's world.
Thank you so much, Kunjan. Thank you for moderating this really well. And thank you, Dr. Prafulla, for having me and organizing this. So I'll start my presentation. I'll basically go through the different applications that are there of artificial intelligence in ophthalmology. And that's something that has been asked in the DNB exams as well. And I think that's pretty much what they will focus on. So to begin with, what is artificial intelligence? Today's residents, the younger generation today actually knows artificial intelligence much better than all of us, and everybody's using it. I mean, they're using it to write their thesis as well, and all kinds of things. But artificial intelligence essentially means training a machine to think and then produce output or act like humans do. So if a software is just doing exactly what it has been programmed to do, that is not necessarily artificial intelligence. Artificial intelligence is when a machine is able to think independently and then act. So the important concepts that are relevant to us in ophthalmology as well are machine learning, deep learning. So machine learning is essentially when you train a machine with the data sets that you give it. It requires a good amount of human intervention to train the machine. Deep learning is essentially a subset of that, where with the help of various convoluted neural networks, it is able to think and act independently and doesn't really require that much of human training. Neural networks is essentially like the neurons that exist in our brain, and all of the a large majority of the applications in ophthalmology are because of deep learning. So AI can be grouped on the basis of various factors. It can be grouped based on the capabilities that it has. Narrow AI is essentially when it is trained to do a single function. Most of the AI that we have today is narrow AI. General AI is when it's say like humans who have multiple capabilities, can do multiple things. AI also may be able to do that very soon. And super AI is sort of a theoretical concept where we say that AI can be superior to humans as well. And then it can also be grouped based on the functionalities of what it can do. Now, of course, AI has taken over almost every field in the world right now, and medicine and ophthalmology is no exception. So I'll discuss the various applications. I'll start with posterior segment because that's where it started. That's where AI began to be incorporated. It was in the posterior segment conditions. Now it's also quite commonly being used in the anterior segment conditions. So, we know that retinal conditions such as diabetic retinopathy, ARMD involve a huge amount of screening, which essentially puts tremendous load on the manpower. Now, using AI can minimize the need for these resources, and that's why, with the help of training of data sets, images, etc., there have been algorithms that have been created where DR can be diagnosed very, very effectively using AI. And for example, this study by Abrameff et al. And this model that they've created is able to diagnose DR with huge sensitivity and specificity, and they did not miss any cases of severe NPDR, PDR, or macular edema, which is essentially what the objective is here. Even the Google AI team did extremely well with the detection of diabetic retinopathy by training it with retinal fundus photographs. And because of all of this, there are now FDA approved AI based systems also that are available for detecting diabetic retinopathy, which is a huge change. Even when it comes to ARMD, AI algorithms have been able to produce results which are similar or better to human performance levels. Google DeepMind and Moorfields have developed a model where it is able to classify various retinal diseases and triage them into whether they are urgent, semi urgent, routine, or just observation, which really helps take the load off of manpower. You don't really need ophthalmologists for screening and triaging, you just need ophthalmologists to treat the patients that need to be treated. And that's where AI is going to be taking us further ahead in future. In retinopathy of prematurity as well, there are some barriers that exist currently, such as the diagnosis being a little variable. Different ROP specialists might vary with the grading that they do, or the diagnosis might be a little subjective. Also, there is a shortage of examiners that are trained in ROP screening. So, if AI is able to do that, and AI has been able to do that, so AI models have been able to diagnose plus disease with comparable or better accuracy than humans. They've in fact agreed with the consensus diagnosis more frequently than human examiners have. And they're able to produce a severity score where they're able to essentially point out which children, which premature children need to be treated. And that's something which is extremely, extremely helpful for this condition. Glaucoma, as we know, there is a huge need as well. The prevalence is huge, the burden is huge, and it needs to be diagnosed, it needs to be monitored. We need to assess the changes that are happening to the nerve, and therefore, training of the AI algorithms to detect glaucomatous disc has also been done, and it is something which has given great results. AI models are able to distinguish glaucomatous discs on the basis of images. They are also able to distinguish glaucomatous nerve fiber layer damage from normal nerve fibers. They're also able to detect early visual field loss. And even in terms of assessing the anterior chamber angles, they are able to tell you which is an open angle, which is a narrow angle, and which is an angle closure. So these were the applications uh, at the nerve level or the retina level. Now we'll move on to the anterior segment applications. Keratoconus, again, is a condition which you need to detect early. You need to identify the milder or subclinical forms, which sometimes can be challenging, and there are various modalities for imaging which may not always agree with each other. Therefore, AI models have been developed which can discriminate, differentiate keratoconus from normal corneas and give the grading as well. AI models can also identify which individuals may be at a higher risk for keratoplasty. And then in other conditions like infective keratitis, we know how big a challenge it is. You don't have cornea specialists in rural areas, in outreach areas where you need to really be able to identify what the causative agent for an infective keratitis is. And we know the challenges with culture as well. Culture getting results takes time, positivity rate is variable, and therefore AI models again have a role to play here. So, neural network based AI models have been able to identify infective keratitis and classify infective keratitis. They've also been able to detect fungal hyphae when looking at confocal microscopy images, which by itself can take a lot of time, can be challenging. There can be artifacts which humans might confuse them for hyphae, but they might actually be something else. When it comes to imaging the corneal endothelium as well, we have the specular microscopy, but we know that there is quite a bit of noise, there are illumination distortions, and you need to manually delineate the cells. This also can be eliminated and has been eliminated by AI models, where you can efficiently evaluate the endothelium using confocal images. Then there are other applications like in refractive surgery, the ability to predict which individuals are at a higher likelihood of developing post-LASIK ectasia so you can avoid operating on those patients It is also able to predict refractive surgery outcomes. Then there is applications, of course, in cataracts, where, of course, we have, you know, huge prevalence of cataracts, particularly in our country, untreated cataracts as well, and a lot of cataracts in rural areas, outreach areas, where you might not be having trained ophthalmologists to screen. So AI models can grade cataracts. Fundus imaging can also be used to grade cataracts. In cases that have been operated, you can predict progression of posterior capsular opacification. And of course, all of us know about these formulae for IOL power calculation that are available and which most of us are using now. There is applications in pediatric cataracts as well, where again diagnosis can be a challenge, and grading the cataracts, which ones should be operated on, that can be a challenge as well. So these are a whole range of applications that are available now. It's essentially taking over every field where you need to screen, where you need to triage, where human involvement can be minimized. Beyond the anterior segment and the posterior segment, it can also help improve our practice efficiency. And there are models already in place. Some of our EMR systems are using AI to optimize our ophthalmology practice as well. When integrated with teleophthalmology is when AI really becomes extremely powerful, because it enables us to reach areas that we are not able to reach otherwise. Of course, there are limitations as well. And I mean, I don't think I need to go over these in detail, but essentially, some of the limitations are that, many of these algorithms are trained with small samples. There is heterogeneity of patients. For example, if an AI model has been trained only on patients based in New York, if you apply that to patients that are in India or in Africa, it may not be as effective. Reporting bias might be there. We only know about the AI models that are doing extremely well. We may not know about the AI models that did not do very well. It's also important to really see that these models are giving us better clinical outcomes and not just, looking at the sensitivity and specificity of it. Then, of course, there is the medical, legal, and regulatory challenges that exist. How comfortable would an individual be taking the diagnosis not from a human doctor but from an AI model? And what if it is wrong? What if something goes wrong because of the diagnosis or the prediction that an AI model gave you? Would the doctor be responsible or would the AI be responsible? So, these are all challenges that we will have. So, to summarize, AI is definitely transforming the field of ophthalmology like it is transforming every other field now. There are very promising results in detecting and classifying posterior segment as well as anterior segment diseases, and it'll help improve diagnostic accuracy and also help us predict where that condition is heading in future. We do need to address the challenges, which are the limitations that I discussed, and we need data sets which are more spread out, involving different geographies, so that AI can really reach its full potential. Now, I've discussed all the applications of AI in ophthalmology because this is something that has been asked for DNB residents in their exams, and I think now, because of more and more applications, we might possibly have an examiner asking you about specific applications of artificial intelligence, say in diabetic retinopathy or specifically in, say, anterior segment conditions. And I think this overview should put you in a good position to be able to answer that question. Thank you. Thank you very much.
Thank you so much, Dr. Tushar, for taking this topic very nicely. So, I think we'll wrap up the session today. It was a pleasure having all of you as the speakers for tonight. And I'm sure all the postgraduate students will benefit a lot. Handing it over to Dr. Prafulla, sir.
Hi, Dr. Praful.
Praful, sir? Praful, sir?
Hello.
Yes, yes, sir.
Yeah, Gunjan, are we done?
Yeah, we have completed our session. We have completed all the
So
speakers.
thank you so much, students. And today it was really a great day because all these topics, AI, genetics in ophthalmology, all these things are difficult topic, and you may not get it from textbooks. So this is a very important module today that we had. And thank you to all the speakers, especially Sir for that NPCB lecture, and Purna for that talk on genetics, and Gunjan, Pranita, all of you did really great. And with this, we are coming to conclusion of this ophthalmology crash course modules. So we did 6 modules, and Madhuvanti, Dr. Anu, Dr. Pranita, all of them helped me a lot. And thank you so much. Thank you so much to all the moderators, Gunjan and Ankit. It's very difficult to sit from 6 to 9 p.m. But if people really had that patience to hear and moderate this session, thank you everyone. And Gunjan and Ankit, you both deserve to conclude the session.
Sure. Thanks. Ankit, are you there? I think Ankit has slept off. Okay. So we'll like to wind it up. Good night to everyone. And thank you so much for being with us today. Thank you so much, Prafulla sir and Dr. Anu ma'am.
Just to inform you, we had 1690 registration for today's module.
Oh wow, that's really nice.
Yeah, somehow we are getting huge responses. I think by God's grace, or I don't know.
That's really good.
Students are very kind to us.
And so we should do it more often, sir.
Yeah.
Yes, every
The
six
topics
months
are
we'll do this.
the topics were
Yes,
very
sir.
nicely chosen also, because postgraduate students may not get this much exposure in books.
Yes. So thank you, Ankit. Thank you, Gunjan. Thank you, Tushar. And thank you, iPhone. I don't know whose iPhone. Is it me or what? I think
You
it's
are the
me.
iPhone,
That's
sir.
you. That's you. Good to see you,
Thank
sir.
you. Thank you. Thank you. Thank you, everyone.
Very nice. And this will
I'm
be there on
running a little
YouTube
bit
also, no?
viral now, so I
Is it?
couldn't join in
No,
between.
no, that's okay. You have a lot of work to do. You
Yes.
look pretty tired also. I think there's a you're doing.
Thank you. Thank you.
Yes.
Good night, all.
See you. Good night. Good night.